Thank you, and welcome back. Okay, to tee up pneumococcal vaccines, Dr. Reingold.
Thank you, and good morning. So I'm going to introduce this next section on pneumococcal vaccines as head of the pneumococcal vaccine work group. So a reminder that the work group includes Dr. Bennett, and Dr. Kemp, Dr. Hunter, and Dr. Lee. We obviously have representation from a variety of other important organizations, and of course, Dr. Pilishvili is our boss. And I want to just take a moment and thank her for her efforts over the years. She's really been extraordinary, and to congratulate her on receiving her PhD just a few weeks ago. So congratulations. So the current terms of reference for the work group are to review the data on efficacy, effectiveness, immunogenicity, and cost effectiveness of pneumococcal vaccines, to review current recommendations considering the most up-to-date evidence, including epidemiologic studies, post-licensure, and to assess the strength of the evidence using our standard grade approach, and to revise or update recommendations for pneumococcal vaccine use as needed. Now, this is simply to remind you of the history of the recommendations of PCV13 over time, recommended for use in children in 2010, immunocompromised adults in 2012, and then by ACIP in 2014 for use in all people over 65 years of age and older. Now, to remind you that in August of 2014, at the time that ACIP made that recommendation, it was considered at least a short-term recommendation. There was a recognition that the herd immunity being generated by vaccination of children might limit the utility of a universal recommendation in this age group. I think it's fair to say that not everyone in the United States agreed with this particular recommendation or thought it would be cost-effective based on the feedback we received, some of it public, so that the magnitude of those indirect effects is really unknown, and that there's certainly a lot of lack of clarity about the burden of vaccine-preventable non-bacteremic pneumococcal pneumonia and the difficulties of studying that. So the ACIP at that time recognized that there'd be a need to reevaluate the recommendation for the routine use of PCV13 in those 65 and older, and set a time for that for next year, 2018. And now that reevaluation is going to presumably rest on data from a number of sources, including monitoring pneumococcal disease and vaccine impact in those 65 and older, attempting to tease apart the indirect vaccine effects on pneumococcal disease trends among unvaccinated adults, and potentially parse that out among the indirect effects from vaccinating children and potentially the effects of vaccinating other groups, and to routinely update ACIP on these various studies and data leading up to discussions next year in 2018. So a year ago at this time, ACIP was updated on changes in pneumococcal disease burden in various groups, and ACIP was presented with an outline of a research agenda that would inform any possible policy changes in 2018. So today we're going to have several presentations. We'll have two presentations on pneumococcal colonization studies, one by Steffi Thomas from the Georgia Emerging Infections Program, and one from Fernanda Lessa here at CDC. Then we'll have a presentation on changes in invasive pneumococcal disease in children, adults, and adults with HIV by Dr. Elmeya Matanak here at CDC. And then Dr. Pilishvili will provide some information about progress of the research to inform policy reconsideration in 2018. So the questions for today's discussion is, does ACIP think the proposed research agenda is appropriate for helping determine the possible need for policy changes in 2018? And what additional information will the ACIP need or want to help it do its deliberations in the year to come. So with that as introduction, Steffi.
My name is Stephanie Thomas. I'm a co-director at the Georgia Emerging Infections Program, or EIP. I'll be discussing the Georgia EIP's Pediatric Pneumococcal Carriage Study. I would like to first acknowledge our team that conducts the Carriage Study, especially the principal investigators, Dr. Monica Farley and Dr. Shabnan Jain, and also Amy Tunali. Nasopharyngeal swabs were collected from children 6 to 59 months of age, presenting to the emergency room at a children's hospital in Atlanta. Children presenting for any reason were eligible as long as they were deemed stable by their physician. I will be discussing 2 time periods during this presentation: the pre-13-valent pneumococcal conjugate vaccine, or pre-PCV13 era, from January through August 2009, and the post-PCV13 era from July 2010 to June 2017. Nasopharyngeal samples were collected on flock swabs, stored in transport media, and frozen at -80 degrees Celsius until processed in the Georgia EIP laboratory. Specimens were then placed in enrichment broth for 4 hours, cultured, and identification of Streptococcus pneumoniae confirmed. All lab-confirmed pneumococcal isolates were sent to the CDC streptococcal lab, where they were serotyped by the quelling method and tested for antimicrobial susceptibilities by broth microdilution. An interview including presenting symptoms, demographics, and potential risk factors was conducted with the parent. Vaccination history was collected from the Georgia Vaccine Registry. Up-to-date status for PCV13 was determined using the children's age at enrollment, current ACIP vaccination recommendations, and pneumococcal vaccine history. Carriage data was compared to data collected through the Georgia EIP's active bacterial core surveillance for invasive pneumococcal disease, which was conducted in the same population in the same time period. During the pre-PCV13 period, 451 children were enrolled. 31% were colonized with strep pneumoniae during this time period. 22% of pneumococcal isolates were PCV13 serotypes, most of which were 19A. During the post-PCV13 period, 4,765 children were enrolled. 30.4% of these children were colonized with strep pneumoniae. I will discuss the serotype trends during the post-PCV13 period in the following slides. This slide shows the demographics and risk factors associated with pneumococcal carriage in the post-PCV13 period. The mean age of children who carried pneumococcus was 25 months, compared to 28 months in those that did not. During the post-PCV13 period, carriage was significantly higher in children presenting with respiratory infections, otitis media, children attending daycare, children with sibling in the household, and among children of Black race. Overall, pneumococcal carriage rates were similar in children who were up to date for their age for PCV13 vaccine compared to those who were not, at 30% and 29% respectively. However, children who were up to date for PCV13 had a significantly lower carriage rate of PCV13 serotypes at 1.8 per 100 study population compared to children who were not up to date who had a rate of 5.7. By late 2012, most children were up to date for PCV13 vaccination at more than 90%. This slide shows the rate of PCV13 carriage and percent up to date with PCV13 vaccine during the post-PCV13 period. Shown in blue is the PCV13 carriage with rate per 100 study population on the left axis. The red line shows the proportion of children up to date with percent on the right axis. The x-axis shows the time period in 6-month intervals. As shown in red, our study population had a rapid uptake of PCV13 vaccine, with nearly 80% of children with up-to-date status by December 2011. The blue line demonstrates that PCV13 serotype Carriage declined from 8 per 100 study population to less than 4 by December 2011, and then was 0.3 in 2017. The graph demonstrates that we saw a twofold decrease in PCV13 serotype Carriage by the time 50% of children were up to date with PCV13 vaccination. This slide shows the difference in rates of pneumococcal Carriage serotypes from the pre-PCV13 period compared to the post-PCV13 time period. The y-axis is the difference in rates, where 0 is the same rate in the two time periods. Positive numbers show an increase, while negative numbers show a decrease. The serotypes are grouped by those in PCV13 in red on the left, then the PCV13-related serotype 6C in green, and then the remaining non-PCV13 serotypes on the right in blue. 19A decreased significantly, while other PCV13 vaccine types did not. 6C also declined significantly. Modest increases were seen in non-PCV13 serotypes. This slide shows the PCV13 serotype Carriage during the post-PCV13 period by year. The y-axis shows the Carriage rate per 100 study population, and the x-axis shows the serotypes. The bars on the far left of the chart show the combined PCV13 vaccine serotypes from 2010 to 2017 in different colors. This combined PCV13 rate significantly declined from 8 per 100 study population to 0.3 per 100 study population in 2017. Key serotypes are to the right by year. 19A significantly declined. 3 and 19F remained relatively steady over this time period. And 6C rates also significantly declined. There is evidence of cross-protection against serotype 6C from vaccine serotype 6A and PCV13. This graph is similar to the previous graph, but shows the non-PCV13 serotype Carriage rates in the post-PCV13 period by year. The y-axis is again the Carriage rate per 100 study population, but note is much higher. The x-axis shows serotypes. The bars on the far left show the non-PCV13 serotypes combined, except for 6C. After an initial increase in the non-PCV13 serotypes from 2010 to 2011, the rates have remained relatively stable. No one serotype has emerged as a dominant Carriage serotype, as shown on the right. This slide shows the distribution of pediatric invasive disease on the left, compared with nasopharyngeal Carriage in the same age group on the right, and this is for January 2016 through April 2017. Please note that invasive pneumococcal disease cases have significantly decreased to only 28 cases in this recent time period. Currently, children are carrying a broader diversity of serotypes than those that are causing invasive disease, as shown on this slide. A subset of serotypes are commonly carried, but are not among those causing invasive disease. This includes 6C, 11A, 7C, and non-typable strains. In conclusion, overall pneumococcal Carriage was stable throughout our study at 30%. Significant reductions of serotype 19A Carriage occurred after introduction of PCV13. Carriage of 6C, a vaccine-related serotype, also significantly decreased. Very low-level Carriage of PCV13 vaccine serotypes persists, including serotypes 19F, 3, and 19A. Carriage of the vaccine-related serotype 6C also persists. No single non-vaccine serotype has emerged as a dominant Carriage serotype. Invasive pneumococcal disease serotypes are generally similar to Carriage serotypes, with the exception of serotypes 11A, 7C, 6C, and non-typable strains, which did not cause invasive disease. Thank you very much.
Thank you very much for that nice presentation. Would people like to ask a few questions before we move on to the adults? Yeah, Dr. Reingold.
So thank you for that. So if I look at the graph correctly, it looks like Carriage was pretty stable between about 2011 and that Carriage and coverage in kids was pretty stable following wide-scale uptake of the vaccine in kids. And so the interesting question would be, can you break out your data pre and post introduction of the vaccine into the elderly to see if that's had any impact on Carriage in children pre and post introduction of the vaccine into the elderly? Because it seems to me that's the question that we're really interested in, right?
Yes, I think, thank you for your question. I think we could. We have a fair amount of data, and so we could look at different time periods. Thank you. Oh, I'm sorry.
Dr. Kemp?
So I had two questions. First of all, it's interesting that you're swabbing from the emergency room samples. Is there any thoughts about how that might affect carriage rates in that you're obviously enriching certain types of things, and have you looked in subgroups, for example, trauma versus, that's my first question. Secondly, there is no relationship, right, between the sample that you're looking at for carriage surveillance and the overall IPD sample, right? That's reported cases for the state, or?
We are looking, our surveillance is done in, as you said, the emergency room in a children's hospital that it acts as a tertiary care facility as well as kind of a community ER in Atlanta. And then our invasive disease surveillance is also in Metro Atlanta. So very similar populations. And your first question?
It's related to potential bias introduced by surveillance in the ED.
So we do ask for what their admitting reason for admission is, and so we would be able to do a subset analysis on different populations.
Thank you. Dr. Kimberlin.
David Kimberlin, AAP Red Book. I apologize if you covered this, but I'm going to focus on racial differences, and specifically continued in the post-PCV13 era, continued increased carriage by Black children. Is that how I understand it?
Yes, our carriage rate is higher in Black children.
Has that changed at all in the time since introduction of PCV13, or did you simply lump pre and post?
We looked at, specifically for this analysis, at the post period, but it was that entire time period from 2010 through 2017. We would be able to break it down into smaller time periods.
Thank you.
Dr. Stevens?
A very nice study. Density is now becoming an issue in terms of colonization. Did you look at density at all in terms of amount of organisms carried, which is an area of some interest now on these in colonization?
No, we did not look at density.
Okay, thank you very much. Dr. Lessa?
Good morning. Although most times pneumococcal colonization of the upper respiratory tract is asymptomatic, it can also lead to invasive and non-invasive pneumococcal disease. Pneumococcal colonization in U.S. adults 65 years of age and older is not well described. A study done in HIV-infected adults from 2005 through 2007 only found 3.4% pneumococcal carriage, while another study in Native Americans among household members of children under 9 years of age found a pneumococcal carriage rate of 9.3% in adults 40 years of age and older. However, in this latter study, only 7 participants were 65 years of age and older. In the UK, a pneumococcal carriage survey conducted in 599 adults 65 years of age and older, prior to PCV13 introduction into the National Infant Immunization Program, found a 2.2% pneumococcal carriage rate. It has been documented that pneumococcal conjugate vaccine decreased vaccine type, but not overall pneumococcal colonization. In a study in Kenya, vaccination of children with PCV10 led to a decline in vaccine type carriage from 33% to 14% in HIV-infected parents 18 months after vaccine introduction, while pneumococcal carriage rate remained stable at 35%. We conducted a cross-sectional pneumococcal carriage survey with the following initial objectives: to describe pneumococcal carriage prevalence and serotype distribution, to assess risk factors for pneumococcal colonization, to provide the baseline carriage data prior to a widespread use of PCV13 among adults in order to assess the impact of the new PCV13 recommendation. These objectives change a little bit during the course of the study when we start to do some preliminary analysis, and I will describe this later. We used the ABC's Emerging Infectious Programs infrastructure to conduct this study in 4 states: Georgia, Maryland, New York, and Tennessee. All 4 of these sites had clinical research units or databases with individuals in our target age groups. Sites also enrolled participants from senior residential communities, senior day centers, and geriatric outpatient clinics. Enrollment began mostly in summer of 2015 and ended at the end of 2016. Participants were screened for eligibility using a standardized screening form and consent for participation. Participants were then asked a series of questions, including history of recent illness, chronic conditions, and recent exposure to antimicrobial or healthcare settings. We also asked a series of questions about vaccination and healthcare exposure to help identify where an individual might have received vaccines since August 2014. We then collect both NEP and OP specimen and place them into 2 separate vials with transport media. After enrollment, study teams followed up with providers indicated by the participants in the questionnaire to document vaccine history. No verbal reports of vaccine from study participants were considered. Participants were included in the study if they were 65 years of age and older at the time of specimen collection, not severely immunocompromised based on the 2012 PCV13 recommendations, agreed to participate in the study, and had both the NEP and OP specimens collected. Participants from nursing homes were excluded. On this slide, you see 2 sample size calculations. We initially assumed a 2% baseline colonization rate with PCV13 serotypes and a 50% reduction in vaccine type carriage after PCV introduction in adults, with a 65% vaccination coverage at a follow-up survey, resulting in a target sample size of 2,970 participants. However, mid-study, we had to adjust our sample size based on preliminary finds, indicating a very high vaccination coverage among participants and low vaccine type carriage. With the goal of solely assessing pneumococcal carriage and vaccine type, we use a point estimate of 0.5% for vaccine type carriage with an upper and lower bound of 0.25%, resulting in a sample size of 3,049 participants. Both culture and molecular methods were used for detection of pneumococcus. NEP and OP specimens were collected, stored, and processed separately. Pneumococci were identified by susceptibility to pitokin and biosolubility. Pneumococcal isolates were serotyped by conventional quellon. We also did antimicrobial susceptibility testing, which I will not present today. For molecular detection, nasopharyngeal specimens were determined to have poor quality if there was no RSV gene detected, and those people were excluded from the laboratory analysis. Pneumococci were identified by detection of the Lych-A gene by PCR, and multiplex PCR for serotype identification was done for specimens that were Lych-A positive. Based on the paper published by our group in 2013, we did not include molecular testing for OP specimens, based on concerns that other streptococci confound serotype-specific PCR assay. This confounding issue was primarily observed with OP specimens due to diversity of streptococcus species found in the oral cavity. A total of 3,008 participants were enrolled in the study, meeting 98.7% of the target enrollment. Georgia was the largest catchment area, so they had a large enrollment target. This slide shows the demographic characteristics of study participants. Compared to the 2015 American Community Survey from the U.S. Census Bureau, the median age of our study was 75 years, and similar to the U.S., the median age, the U.S. population. And the percentage with healthcare insurance was similar to the U.S. However, we enrolled a larger proportion of African Americans and also females. Most people reported living alone or with one other person, with a range of 1 to 10 persons per household. We did ask whether young children lived in the household with the participants, but very few people reported any children in the household. Approximately 7% of participants reported smoking, which is consistent with what CDC reports for this age group. 40% of participants reporting having at least one chronic condition, which is listed on this slide, with cardiovascular disease and diabetes being the most common conditions. We did ask participants whether they had pneumonia and flu in the 1 month prior to the enrollment, and less than 1% reported either. 4% of the individuals reported taking antibiotics in the 2 weeks prior to specimen collection. Of the participants with known vaccination history, almost half had already received PCV13 at the time of enrollment. Our study teams did a really great job of following up on vaccination histories, and only 5.6% of the participants enrolled have unknown vaccination status. Maryland participants had the highest PCV13 coverage at 54.7%, with Georgia having the lowest coverage at 41.9%. PPSV vaccination rate is likely underestimated because we did not require sites to look very far back in the medical records. Some sites did record PPSV from the late 1990s, but only if that was readily available. All sites were required to review all health records back to August 2014, but some sites end up reviewing prior records. So of the 3,008 participants enrolled, 24 were excluded from laboratory analysis due to poor specimen quality. Among the remaining 2,984 participants, 45 were culture positive for pneumococcus. Of the 2,939 participants without pneumococcus isolated, 10 were positive for pneumococcal Lych-A gene, resulting in an overall pneumococcal colonization prevalence of 1.8%. Among culture-positive cases, 7 were PCV13 type. None of the PCR-positive cases were vaccine type, resulting in a PCV13 carriage rate of 0.2%. Among the 7 adults with vaccine type pneumococcal carriage, the serotypes isolated was 3, 19A, and 19F. which are also the most common serotypes causing invasive pneumococcal disease in U.S. adults aged 65 years of age and older, as it will be shown in the next presentation. Among non-vaccine types, 11A was the most common, followed by 23A, 23B, and 33F, 33A, and 37. Pneumococcal carriage rates did not differ by vaccination status. Among vaccinated individuals, pneumococcal colonization was 1.8% compared to 1.6% among non-vaccinated. Vaccine type carriage was also similar among vaccinated and non-vaccinated participants. In summary, we found an overall pneumococcal carriage prevalence of 1.8% in U.S. adults. This prevalence is similar to what the UK observed in the same age group after PCV7 introduction and before PCV13 introduction into their National Infant Immunization Program. PCV13 type pneumococcal carriage was 0.2% in our study. In the UK study, 5 years after the routine PCV7 use, PCV13 type carriage in persons 65 years of age and older was 0.5%. In conclusion, carriage of pneumococcus is rare in the U.S. adults who are not institutionalized in nursing homes. PCV13 serotypes account for only 13% of those with pneumococcal detected. Both vaccinated and unvaccinated individuals in our study had less than 0.5% vaccine type carriage. Many years of PCV vaccination of kids may have led to herd effects in adults. However, given the low vaccine type carriage rates we observed in an already high PCV13 adult coverage setting, it's very difficult to attribute our finds to direct versus indirect effect of PCV on adult carriage. I would like to acknowledge CDC colleagues and especially all the study staff across the participating ABC sites who made the enrollment of over 3,000 senior Americans possible. Thank you.
Thank you for that excellent presentation of a great study, because I'm not biased at all. It's wonderful to hear the results presented. Thank you. Questions? Dr. Reingold.
So Fernando, that was very nice. Thank you. And I recognize because of the low carriage rates, you probably can't look at predictors of carriage. But I'm curious, you didn't show any data about what proportion of these free-living elderly have contact with young children. And I'm just curious, do we know much about that issue in the United States? What proportion of the elderly have regular contact with young children?
Yeah, we just really asked the question about children in the household, and then very, very few, like a handful.
Dr. Hunter?
I noticed that the rate of smokers, if I'm reading it right, was 6.8%. Is that correct?
That's correct.
That seems low. Is that?
Actually, in our community surveys, that's about what it is for older people. It's much higher in younger people.
Got it. Thank you.
The CDC data, based on the CDC data in the US, is 8% in US adults at this age group. And we find 7%. Dr.
Duchin.
Thank you. I'm curious about your thoughts on the implications of the Carriage studies on invasive disease incidence in adults. These cross-sectional studies tell you something about the prevalent Carriage strains, but it's not clear that those are the ones that are most responsible for invasive pneumococcal disease, and it may be the recent acquisition of a new strain that's more related to the development of invasive pneumococcal disease. So I'm just not sure how that I can make sense of that right now, but I'm hoping that you can. And tell me a little bit about how you're thinking, we can get a better handle on those strains that might end up causing invasive disease, rather than just those that are carried sort of harmlessly over longer periods.
Yeah, thanks for the question. It's a great question. And Dr. Almia Matanoka was going to present the data on invasive pneumococcal disease. And the serotypes that we found the 7 patients that had vaccine type carriage, the 3 serotypes 19F, 19A, and 3 are also the most common serotypes causing invasive pneumococcal disease based on the ABC's data. And Almia is going to show that later on, so you can have the linkage between what we found and what's going to be shown in the next presentation.
Can I also add one comment to that? I think you're asking a really interesting question, and actually there's another study that's ongoing that I don't believe has been completed that Ann Falsey is doing, where she's looking at carriage over time. So they're resampling people over the course of a couple of years, I believe, and her carriage rates per person are considerably higher because of the doing it over time. So it'll be very interesting to see the results of that. Dr. Whitney.
Yes, if I could just add one thing, Cindy Whitney from Respiratory Diseases Branch. I think if you think of these serotypes as, people getting exposed to them and then having them for some time, and we sample in the middle of that, for me, this suggests that the older adults really aren't getting exposed to the vaccine types all that much, at least relative to the other ones. And probably they're not getting exposed to pneumococcus all that much at all, and if they are, they're not carrying it very long.
Just on that topic, I might have missed it, but seasonality might have something to do with the level of carriage as well, and I don't know if that was accounted for in the study.
Our carriage rates were so low that it's going to be really difficult to look at seasonality, but yeah.
Any further questions? Okay, I think we'll move on to the next presentation. Dr. Madana.
Thank you. Good morning. I think we're still morning. So I'm going to present on invasive pneumococcal disease in the United States. So just to review again what Art has already shown us in terms of PCV introduction in the United States, and the aim of this is to evaluate the direct and indirect impact of PCV13 on invasive pneumococcal disease in the general population of children and adults, and among adults with HIV. We identify IPD cases defined as isolation of pneumococcus from a normally sterile site through the active bacterial core surveillance, or ABCs, a laboratory and population-based surveillance system ongoing in 10 sites. For our total population numbers, we use the US Census, and for the HIV population numbers, we use CDC's HIV surveillance, which was implemented by 2008 nationwide. Isolates are serotyped by Quellong or PCR at reference labs, and we have grouped them as PCV13 serotypes, which include 6C, as Steppy pointed out, because of observed cross-protection, PCV11, which are the additional unique serotypes in PPV23, and all additional serotypes as non-vaccine types. For this analysis, we compared overall and serotype-specific IPD incidence pre- and post-pediatric PCV introduction. We use slightly different timeframes looking at IPD among adults with HIV because the CDC HIV surveillance data is only available for 2008 through 2014. From the incidence, we calculate the percent reduction for disease incidence. Pictured here are IPD rates among children less than 5 years old, comparing pre-PCV13 rates to post-PCV13 2016 rates. There's a 61% reduction in all IPD, and an 87% reduction in PCV13 serotypes. This percent change was first noted in 2012 and has stayed relatively stable since that time. Looking at just PCV13 serotypes, which again include 6C, the largest declines have been in 19A, followed by 7F. Pictured here are IPD rates among adults 65 and older. Comparing before and after pediatric PCV13 introduction, there's been a 40% reduction in all IPD and a 68% reduction in PCV13 serotypes. Annual rates have plateaued prior to the recommendation for PCV13 in adults 65 years and older, as seen in the period in the red box. The unique PPV23 serotype group, or PPV11, the gray line, there has been no significant change in this group over the time shown here. And again, looking at just PCV13 serotypes, we see the largest reductions in 19A, followed by 7F in adults 65 years and older. And to note here, the relative burden of serotype 3 remained stable, relatively stable over this time. These two tables show the rank order of non-PCV13 serotypes causing IPD among children in the first two columns, and then among older adults in the second two columns for 2015 and 2016. Those highlighted in green are common between both age groups. Additionally, there is no one non-PCV serotype causing the majority of non-PCV13 serotype IPD that you can see here. This here is pneumococcal meningitis incidence. One concern that has been raised is that perhaps there are less blood cultures being obtained because of changes in clinical practice. We thought meningitis would be might be less sensitive to changes in culturing practice, and so looked at it separately. We see the same reductions in PCV13 and overall pneumococcal meningitis as we do in overall IPD. Moving on to characteristics of IPD among adults with HIV. In general, IPD cases with HIV are more likely to be younger, male, and of Black race. IPD case fatality, defined as the proportion of IPD cases who died from IPD, were higher for the older age groups, but the proportions were similar between those with and without HIV. At baseline, defined as 2008-2009 time period, we see an incidence rate of 299 per 100,000 of IPD amongst adults living with HIV. In the years that followed, there was significant reduction in incidence by 27% for the time period of 2011 to 2012, and of 36% for 2013 and 2014. Despite reductions in overall IPD, adults with HIV had an 18 times higher risk for IPD than adults without HIV. This here is looking at reductions in PCV13 serotype IPD among adults with HIV. And as reflected in overall, we again see a reduction in 2012, the time period of indirect effects, 2011 to 2012, and then the period of indirect and direct effects in 2013 and 2014 shows a 61% reduction. And again, here, when just looking at the incidence rate ratio of PCV13 serotype IPD, there remains an 18-fold increased risk for adults with HIV. As in the general older adult population, we did not observe any statistically significant changes in unique PPV23 serotypes over time, of the time period of the study among adults with HIV. In summary, there have been significant reductions in overall and PCV13 serotype IPD among children and adults since PCV13 was introduced in the United States. These reductions have primarily been driven by decreases in 19A and 7F. Annual rates have plateaued in the past 2 years. We did not observe further reductions in PCV13 serotype IPD among adults 65 years and older after the 2014 recommendations for PCV13 in this age group. Despite reductions in IPD rates, including PCV13 serotype rates, overall they remain higher in adults with HIV compared to those without HIV. And a better understanding of vaccination rates amongst adults with HIV is needed to fully assess the direct versus indirect impacts in this population. There have been relatively small changes in some non-PCV13 serotypes. However, there has been no large increase in any one non-PCV serotype among children or adults, including those with HIV. And similar trends are observed for pneumococcal meningitis as we see in overall IPD. In conclusion, in the 6 years since PCV13 was introduced, there have been sustained benefits in overall IPD and IPD caused by PCV13 serotypes in children and adults. We have not seen evidence of serotype replacement. However, we continue to monitor for changes in disease and serotype distribution to inform new vaccine policy. And I'd like to acknowledge a few of the people who have been part of the collection and analysis of this data, though know there are many more who have contributed. Thank you.
Thank you. That was a very nice presentation. Questions? Thoughts? Dr. Reingold.
Thanks very much for that. Can you remind us what we know currently about coverage with PCV13 among the elderly?
That's a great, and Tamara, leading into our next talk, will actually present some of the specifics, but Fernanda alluded to it as well, but it's somewhere between 30 and 50% in older adults. We don't know, as I said, for HIV positive adults as well what the coverage is, but suspect that it may be lower because we know it's lower between 19 and 64-year-olds.
Dr. Stevens.
So serotype 3 is persistent. Can you comment on serotype 3 and any issues regarding that particular serotype in the PCV13? This is a great success story, but serotype 3 seems to be the stubborn one.
Yeah, being a pediatrician and not a microbiologist, there are probably others in the room who can comment better on it, but in terms of the structure of it, it is different. I don't know if anybody else wants to say more about that.
Oh,
Dr. Whitney.
Cindy Whitney, Respiratory Diseases. Just to add, these findings are consistent with what other people are seeing, that it's not only in our population but elsewhere, that the benefits of PCV13 against that serotype are not showing through very clearly.
Sorry, Dr. Ezianola.
So I just wanted to be a little clear. So what you could get from all this study so far is that since 2014, when we introduced the adult vaccination, nothing really have changed among the adult population. So the question to me is, do we have that on HIV-infected adult? Do we have that on general adult population? Of any changes, or is it just for the HIV-infected adult?
And in general, adults over the age of 65. But we don't have it in the whole population because we're not vaccinating the whole population.
No, I mean the adults without HIV above 65.
Right,
So
we have those data.
So both of those places, there is no change. Okay.
Correct. Dr. Kimberlin?
David Kimberlin, AAP Red Book. To follow up my earlier question about colonization to your predecessor and black race, there on some of your slides for adults, 19 years and older, there was a correlation with black race and invasive pneumococcal disease. How about in children? Are we exploring differences in outcomes and likelihood of invasive disease by race?
Yeah, thank you for that question. That is analysis that we plan to do both in the younger age groups as well as the older age groups, looking not only at race but also socioeconomic status.
But certainly, the early studies show a marked decrease in racial disparities with the introduction of PCV, right. PCV7 for sure.
And that, agreed, and I just want to make sure that's being maintained and it correlating with number of doses of PCV13, those kinds of things.
Thank you. Dr. Maldonado? Thank you.
I just wanted to follow up.
Dr. Ezeanolu.
So when you talk about the race, is it race or socioeconomic grouping? Because that's always very confusing sometimes. I mean, is there a biological plausible reason why blacks will have more outcome, different outcome, or is it mostly socioeconomic differentiation?
That's a huge question that many people are trying to tackle, trying to parse out the impact of socioeconomic status, crowding, poverty, et cetera, versus whatever the other characteristics might be. And I think it's
so is that being collected? Because if it's not collected, then we're really not going to be able to answer that.
Actually, in the Emerging Infections Program is now being collected quite a lot and looked at very closely, and I can share some of those data with you offline. Dr. Lee?
Just a really quick question. I'm trying to wrap my brain around this. I'm having a hard time with it. So I'm looking at the changes in IPD incidence in adults with HIV and then the changes in IPD incidence among adults over 65. And it both looks like it declines sort of through 2014. So my question really is about, number one, what are the vaccination rates amongst patients, adults infected with HIV in the 2012 to 2014 period, if we know that? And then as a second question, are we able to say how much is actually direct effect versus sort of population level effect, in part because I'm seeing sort of the same trends in the over 65 up to 2014.
Yeah, thanks for that question. Yeah, that was what I was alluding to in the summary, so thank you for bringing that point out further. Yeah, we have some estimates that the coverage in 19 to 64-year-old adults with immunocompromised conditions in this time period, or ending at 2014, may be around 5%. But we think that probably the uniformity of that is not there amongst all the different immunocompromised conditions, and that there's good reason to think that it may very well be different amongst adults with HIV who are of that age. We do know that the immunization rates are much higher for adults 65 years and older, and Tamara will present that. So.
Thanks. Then just as a minor comment, then I guess it's hard for me to say that that is actually direct effect in the 2013-14 era, or it's a combination of the two. But it implies that it's primarily direct effect that's further driving that down.
Okay, thank you very much. That was great, Dr. Pilishvili.
Good morning, everyone. So in the last 5 minutes, I'm going to try to put it into a context of the potential policy decision that we might be facing in 2018, and update you on the progress of the research agenda that we presented about a year ago exactly a year ago to this committee. So when we presented this research agenda, which is targeted to address these three key questions that we think need to be answered in order for us to have enough evidence to make a determination on the utility of the PCV13 use in the elderly population. These three questions were: is PCV13 use among adults 65 and older preventing disease in adults? The more difficult question, but the key question, is to what extent these observed effects are driven by indirect effects from the PCV13 use in children versus the adult use of the vaccine use in the adult population. And also, I guess projecting forward, what benefits would we expect from continued use of PCV13 use among adults? So based on the updates that you heard last year and the presentations that you heard today, this is what we know to date. So we presented updates on the impact of PCV13 on IPD. So what we are seeing is that strong indirect effects had been observed on adult disease burden through 2014. But then we are actually not seeing any additional declines in annual rates from 2015 and 2016. PCV13 serotypes did decline as far as their contribution to overall IPD burden to 22% in 2016 compared to 43% in pre-PCV13. And I think what is important also to point out is Dr. Mattenok showed the impact by serotype within those PCV13 serotypes. So the largest disease burden from PCV13 serotypes was due to 3 serotypes, which is 19A, 7F, and type 3. And 19A and 7F vaccine has been very effective in reducing this disease even through indirect effects. So what's remaining is really serotype 3 on IPD, and we are not seeing any impact on type 3 directly or indirectly from the vaccine. And as Dr. Whitney pointed out, this is very consistent with other settings, and it wasn't exactly surprising based on immunogenicity data. We had even pre-licensure as well as the post-licensure effectiveness studies that look at the effectiveness against specifically serotype 3. So that explains the plateau that we are seeing in 65 and older for IPD. As far as trying to understand what the direct and indirect effects are, we are continually monitoring the impact of the vaccine on disease in the age groups currently not recommended for the vaccine. These are younger than 65. So we have the groups, as Dr. Mattenok presenting, with HIV that are currently recommended to receive PCV13, as well as those that vaccine is currently not recommended. And what we are seeing is that the reductions are very comparable and very similar among adults with and without indications for this vaccine. In terms of Carriage, so the Carriage studies have been highlighted in today's session. The importance of Carriage is it doesn't mean disease, but it is a precursor for disease, and it also gives us a very good snapshot in time and almost an understanding of what are the strains that are circulating in the population. And even though, as Steffi Thomas pointed out, there's greater diversity in Carriage serotypes than in IPD serotypes that we see. In terms of the impact of the vaccine that we have observed in both children and adults, and what we see with disease and the Carriage is very similar. So the same serotypes that declined in Carriage are the same ones that declined in IPD, and the same vaccine serotypes that still persist after post-PCV13 in Carriage are the ones that we see in IPD as well. And it's very similar for children under 5 and for adults 65, although for adults, as you saw, the Carriage rates are so low that we cannot really tease apart among vaccinated and unvaccinated. But nevertheless, the findings we think are consistent with what we see in IPD. Monitoring coverage of the vaccine is important in order to understand how much of this impact we can attribute to the direct effects versus indirect effects. And currently, there are 2 methods or 2 data sources that we use in order to monitor the coverage of PCV13 and PPV-SV23. We have a collaboration with CMS ongoing, where we look at the uptake of the vaccine among Medicare Part B beneficiaries. And also, we are collaborating with Pfizer colleagues where they have a more complex analysis that takes into account IMS claims as well as the vaccine sales data to understand what the coverage in the population is. So this is the first method. This was an MMWR that was recently published by our colleagues in Immunization Services Division. First author is Carla Black. And this is part of the collaboration with CMS. And so what was found through this analysis is, so as you can see in 2014, late 2014 is when the PCV13 for adults was recommended. That's where we had the vote in August. But then the CMS did not change their regulations until January then of next year, where the 2 vaccines in series were covered. So really until early 2015 is when that's when the uptake really started going up of the vaccine. And what this analysis observed is for a single dose of PCV13 received, the coverage through September 2016 increased to 31.5%. And this is any PCV13 dose regardless of the polysaccharide vaccine receipt. For any PPV in the same population, for any polysaccharide vaccine receipt, regardless of the PCV receipt, the coverage went up to 43.2%. And for both PCV13 and PPSV received in series, the coverage increased to 18.3% during the same period. And with the light blue bar here, the first bar, any pneumococcal vaccine receipt is at 56.4% in this population. So this is a little bit lower to what is being reported through a National Health Interview Survey, NHIS, where the coverage for any pneumococcal vaccine was the latest reported was around 64%. But to highlight, the analysis presented on this slide only covers Part B beneficiaries. So the second analysis that I mentioned includes, this is a slide courtesy of Pfizer. The analysis includes IMS claims, but also, which is presented here with the dark blue bars, but also incorporates the manufacturer sales data for PCV13. And there's a complex modeling done to estimate the uptake of the vaccine among adults 65 and older. And based on the claims only, which is a dark blue portion, through May 2017, the uptake was at 31.7%. And if we incorporate the sales data, the coverage was at 51.4%. So I guess it's pretty sizable, measurable uptake of the vaccine is what we're observing in the population of 65 and older. And in terms of what is coming up, so we're not done with our research agenda. There are studies still ongoing. We have 2 parallel vaccine effectiveness evaluations ongoing for adults 65 and older against invasive disease. Those are 2 case control studies. One is utilizing ABC's cases identified through active bacterial core surveillance, and population-based controls we're enrolling, and we're obtaining vaccination histories through primary care providers in order to measure the vaccine effectiveness. And the second one is the collaboration with CMS, where we are linking our ABC surveillance data with Medicare Part B beneficiaries, and we're obtaining the vaccination and medical histories through the CMS database. So both of those studies going in parallel, they are the sample size driven. So we are waiting for sufficient number of vaccine type cases, and we think that through another winter of enrollment, we'll have sufficient sample size to look at the vaccine effectiveness. Obviously, we've been talking about IPD only, and the recommendation was heavily relying in 2014 on the burden of pneumonia. So it is important to look at what the impact of the vaccine has been on community-acquired pneumonia. And there are studies that are ongoing, which we hope to present during the upcoming meetings. They look at different outcomes for pneumonia. There is one where we are looking at just administrative data for all-cause pneumonia and looking at the impact of PCV. We're also conducting surveillance based on the urine antigen Binax positive pneumococcal cases to look at the impact on pneumococcal pneumonia. And then there are industry-led studies which utilize serotype-specific urine antigen tests, which also look at the impact as well as the effectiveness of pneumococcal vaccine against vaccine-type pneumococcal pneumonia. So we hope to share these studies during the upcoming meetings with you. review. And lastly, to bring it all together and try to make sense of all these various post-licensure studies, we'll use a model in order to try to estimate what the public health impact and cost effectiveness of various policy options is going forward. One of the policy options would be, what if we just maintain the observed impact through PCV use in children, and there is no age-based recommendation in elderly? And also, what if we were to expand the recommendation and indications for adults younger than 65 to include those with chronic comorbid conditions, which are currently only utilizing polysaccharide vaccine? And as you saw with previous studies on IPD, there has been no impact observed on PPSV unique serotypes over the same time period. And I think that's it. And thank you for your attention. And any questions?
Thank you very much for that really nice presentation. I think this is a study in looking for a needle in a haystack a little bit, and I can't commend the pneumococcal group enough for doing these really difficult and important studies. And I think it's also a testimony to the value of the ACIP that we're doing this. It would have been really easy in 2014 to say, okay, we're just going to have this recommendation for those over the age of 65 because it makes sense, and not do anything further. So I think this is really taking a long, hard look at what we're trying to do and seeing whether it's having any impact. And I can't really commend you enough for this work. It's critical. Questions? Dr. Hunter.
Am I right in assuming that we will have enough time from the introduction of the pneumococcal conjugate vaccine for people over 65 till we need to make a decision next year to see an effect on pneumonia and pneumococcal pneumonia and invasive pneumococcal disease? I'm making that assumption based on seeing the change in especially children, that you had the introduction and very soon after that you had reductions. Is that correct?
So I think based on what we are seeing right now in terms of the plateau of disease, it's clearly the picture very different from like what we expected. But I think it has to do with the serotype composition and the remaining disease burden, why we are, as I alluded earlier, at least for the invasive disease, that's probably what we expect. In terms of the number of years sufficient to look at the impact, I mean, based on the number of cases that we're observing and some of the modeling studies that are ongoing, we think that having another winter's worth of data would give us sufficient data points to at least say with confidence with what we're seeing, whether it's just year-to-year fluctuations or whether we are seeing an impact. And so that's where a little bit of a delay in some of the studies.
You know, just to put this into some context, I realized sitting here that we're looking, there's 22% of disease that's still caused by these serotypes, and we have a vaccination rate of less than 40%. So you're looking for a needle in a haystack. I mean, it's really going to be very difficult. So, Dr. Kemp.
I just want to make sure I understand that first study as well as I can right now. I mean, that will give us some insight into the effect of the vaccine versus Carriage, I imagine, because we will know if they were vaccinated or not, right?
That's exactly so. Unlike the studies looking at the population level at impact, where we cannot tease apart vaccinated versus unvaccinated, here we are looking at individual level effectiveness. So.
Right.
Dr. Walter?
Yeah, the coverage data you presented is national data. Is there any data in the geographic regions where the ABC surveillance is done?
So the CMS data that are presented is national. The same MMWR does present the estimates by state, and we've also conducted analysis looking at specifically ABC's areas, and there is some variation across the sites in terms of the coverage.
Is it very different for those sites? Or?
I cannot recall right now how it was for ABCs, but was it higher? No, the coverage of the vaccine for ABC sex.
What we are seeing in the data. Yell. So what we saw, and I think that's in the MWR as well, it's usually like the South has a lower coverage than the Northeast. And in the Carriage survey, we saw the same thing, that New York and Maryland had higher coverage than Georgia and Tennessee.
Dr. Messonnier?
I just have two things to say that about this. I'm going to ask just formally that at that upcoming meeting, we also review the vaccine safety data. I know we've seen it, but I don't think you all have seen it sort of in a concerted fashion. So we should add that to the upcoming list. And I also think that maybe the framework that the evidence-based working group is developing might help here, because I think I can see coming down the pike difficulty figuring out how to take all this evidence and turn it into a decision. And so maybe this is also a place that we should utilize that.
It's a great idea. Dr. Brezhnitz.
Yes, hi, Ed Brezhnitz, Merck. Nice presentation, Tamara. Just to point out that the Merck has also used IMS claims to look at this issue of whether individuals have gotten both doses of the vaccine subsequent to the policy recommendation, and we're finding the same level of completion as you know. Could you comment on to what extent not getting that PPV-23 is a function potentially of the individual not being eligible to get it because they might have gotten it less than 5 years before they got PCV-13? Because that would impact on the percentage that would be eligible and sort of the percentages that you're reporting.
Yeah, that is a good point, and I don't think the analysis of coverage for both doses presented here addresses that, and probably not a good way, as you just mentioned, because some people would not have been eligible to receive the second dose, or they might have already received the previous dose, and because of that, they didn't receive the PCV-13. This way of looking at the cohort is probably not appropriate to assess to what degree receiving one impacts the receipt of the second one, but we will have ability to look at that with other analysis that we're conducting.
Any further questions, comments? Great. Thank you very much for an excellent update, and we'll be moving on to anthrax and Dr. Stevens.
So good morning. I'm David Stevens. The anthrax vaccine work group has been reconstituted, and I am the chair of the working group. The ACIP members, our member including myself, is Dr. Atmar, Robert Atmar, and these are the members, ex officio members, liaison representatives, invited consultants, and our lead for this work group is Dr. William Bauer, who will be presenting next. The terms of reference for the committee are to review new data on anthrax vaccine absorbed AVA, including new safety studies, studies on immunogenicity, reactogenicity, logistical considerations for administering AVA via the sub-Q or IM route for administration as post-exposure prophylaxis PEP. Future deliberations will include AVA plus CpG 7909 as an adjuvant, and that data for use as post-exposure prophylaxis. Additional efficacy and immunogenicity data on dose-sparing strategies for PEP during a mass casualty incident when AVA is a limited resource. Data on reduced booster schedule for pre-exposure prophylaxis, and advice on the use of AVA and antitoxin for PEP when no effective antimicrobials are available or have an absolute contraindication. Today's session will discuss preparedness, operational concerns during an anthrax mass casualty event, review new safety data, in particular adverse events related to IM versus sub-Q route of administration, and review data on immunogenicity for IM versus sub-Q route of administration. And with that, I will turn it over to Dr. Bauer.
So, good afternoon. Anthrax vaccine is different from most vaccines discussed by ACIP as is not part of the routine vaccine schedule. One of the license indications is for pre-exposure prophylaxis in certain groups that are at risk for exposure to Bacillus anthracis. However, the pre-exposure prophylaxis indication is for a very few groups of individuals. CDC's questions for ACIP mainly concern the use of anthrax vaccine as post-exposure prophylaxis following an intentional release of aerosolized spores. In this presentation, I will discuss some of the operational concerns related to administering anthrax vaccine during a large anthrax event to help us understand why we're asking these questions. So the main purpose of this talk will be operational concerns for providing post-exposure prophylaxis during a large anthrax event. But first, I will provide some background on anthrax vaccine. This vaccine is quite old and has a long history. It was first developed at Fort Detrick in the 1950s, and in the 1970s was licensed and manufactured by the Michigan Department of Health for use in individuals at high risk of exposure to anthrax. Today, the vaccine is known as Anthrax Vaccine Adsorbed, or AVA, and is manufactured by Emergent Biosolutions under the trade name BioThrax. The final product is a sterile, cell-free filtrate made from an avirulent strain of Bacillus anthracis and contains aluminum and 2 preservatives. The primary immunogen is protective antigen released during the growth period. The vaccine contains no live or dead bacteria. As a reminder, here are the changes in approved indications since ACIP published anthrax vaccine recommendations in 2010. In 2008, the route of administration was changed from subcutaneous to intramuscular for pre-exposure prophylaxis, and the priming dose at week 2 was eliminated. In 2012, the priming series was changed to 0, 1, and 6 months, as data indicated protection was achieved at 6 months. AVA was first approved in the European Union in 2013 as a 3-dose priming series with a booster dose every 3 years. And AVA was given a post-exposure prophylaxis indication in 2015. Other important updates include additional safety studies and new data from studies used for the post-exposure prophylaxis indication and a planned BLA application for AVA plus the new adjuvant CPG 7909. Also, studies were done to support dose-sparing strategies if vaccine needs exceed supplies. So just to summarize, here are the current AVA pre-exposure and post-exposure prophylaxis licensed indications for adults 18 to 65 years of age. Now, to set the stage for AVA use in a large anthrax event, I will talk a little about anthrax as a bioweapon. Bacillus anthracis spores are considered one of the most likely bioweapons because they are relatively easy and cheap to produce, can be produced and stored in large amounts, and are easy to covertly disseminate, and once disseminated, they can remain a potential exposure risk for a long time. Anthrax has been used as a bioweapon and is also known to cause widespread illness and disease in unprotected populations. The picture to the right illustrates the plume that resulted from an accidental release of spores from a Soviet bioweapons facility in 1979. This incident resulted in at least 79 cases of anthrax and 68 deaths. More recently, in 2001, there was an incident in the United States where spores were sent through the U.S. mail. Direct exposure to letters and presumably to items that were cross-contaminated by letters resulted in 22 cases of anthrax and 5 deaths. The U.S. government preparedness plans include scenarios where a wide area outdoor aerosol release in a densely populated area could expose millions to Bacillus anthracis spores. This slide depicts a hypothetical wide area release generated by an aerosolizing device on a DC metro train. In this hypothetical scenario, thousands of people would be initially exposed in the train stations, but when the train emerges to travel above ground, winds carry the spores over densely populated areas, exposing hundreds of thousands. Now we'll discuss the U.S. government's planned response for a large anthrax event. The federal government, through the CDC's and Prevention's Strategic National Stockpile, will respond to release of Bacillus anthracis spores by deploying antimicrobials, antitoxins, vaccine, and other medical countermeasures. The current plan is to provide 60 days of oral antimicrobials in conjunction with a 3-dose course of anthrax vaccine to those potentially exposed to aerosolized spores. For this post-exposure prophylaxis plan to be most effective, the prophylaxis should be administered as soon as possible. This graph depicts the 60-day anthrax response timeline. Immediately following the federal decision to deploy medical countermeasures from the Strategic National Stockpile, CDC will deliver a 10-day supply of oral ciprofloxacin and doxycycline for the potentially exposed populations. The goal is to dispense the post-exposure prophylaxis antimicrobials within 48 hours of the decision to deploy assets. The deployment process for the 50-day supply and ancillary supplies begins immediately following shipment of the initial 10-day supply. 50-day oral antimicrobial supplies will arrive no later than 8 days after the federal decision to deploy. The first dose of AVA will be shipped along with the 50-day supply of oral antimicrobials and administered when the 50-day supply of oral antimicrobials is dispensed. The second and third doses of AVA will be shipped separately and administered 2 and 4 weeks after the first dose. IV antimicrobials and antitoxin will also be available upon request from healthcare facilities. Here are some of the operational concerns related to a large anthrax event that prompted CDC to ask ACIP on advice on route of administration. As a reminder, AVA for post-exposure prophylaxis is currently licensed for administration only by the subcutaneous route. Subcutaneous vaccinations are usually given with a 5/8 inch needle, while intramuscular vaccinations are given with either a 1 or 1.5 inch needle. In a large event, CDC's supply of 5/8 inch needles may be insufficient to administer vaccine by the subcutaneous route. There also may not be enough available from commercial suppliers in the short term to fulfill the needs. CDC also stockpiles 1-inch needles for intramuscular vaccine administration. In a large event, needle supplies may only be met through use of both 5-inch needles and 1-inch needles. Anthrax is the next generation human anthrax vaccine, which is currently in phase 2 trials. Anthrax is expected to be licensed for IM administration only. CDC's Strategic National Stockpile will transition to Anthrax in 2008 for use under an emergency use authorization while the company seeks licensure. During transition from AVA to Anthrax, which is expected to occur over 4 to 5 years, the stockpile will have 2 vaccines with 2 different routes of administration, which could lead to administration errors with both vaccines. Administration of vaccines to potentially millions of individuals relies on the most efficient method available. Most vaccines are given by the intramuscular route. Thus, there is more experience in the healthcare community giving intramuscular injections, and this route may be more efficient for vaccinating large numbers of individuals over a short period of time. Adherence to antimicrobials is another concern. Post-exposure recommendations for individuals exposed to aerosolized spores are to take 60 days of oral antibiotics in conjunction with 3-dose course of anthrax vaccine. With this strategy, the antimicrobials provide protection against germinating spores until the vaccine elicits a protective immune response. For this strategy to work, adherence to taking oral antimicrobials is, as recommended, is of critical importance. A paper from 2002 looked at adherence to PEP antimicrobials involving persons exposed at 6 U.S. sites where letters containing Bacillus anthracis spores were sent through the U.S. Postal Service. Approximately 10,000 persons were advised to take at least 6 days of antimicrobial prophylaxis to prevent inhalation anthrax. Of these, 6,178 were interviewed for adverse events and adherence. Most respondents were aged 40 to 64 years, and 60% were male. In this study, of the 6,178 respondents, 13% either never collected antimicrobial supplies, or if they collected initial supplies, then never initiated PEP. Only 44% of respondents reported taking antimicrobial prophylaxis for at least 60 days. Of the 2,631 persons taking at least 1 dose of antimicrobial prophylaxis but stopping before 60 days, 43 stated that adverse events were the most important reason they discontinued prophylaxis. 25% reported perception of a low risk of anthrax, and 7% identified fear of long-term side effects from antimicrobial prophylaxis. This graph shows the adherence at the 6 sites. Adherence through 60 days was highest at the Brentwood facility at 64% and lowest at the New York City facility at 21%. The authors of this study concluded that risk perception was the strongest predictor of adherence across the 6 exposed cohorts. In another study looking at adherence following potential exposure to Bacillus anthracis spores that happened at a lab at CDC, we contacted 42 individuals who were recommended 60 days of antimicrobials. As you can see, this is a small study with only 29 respondents at 30 days and 18 at 60 days. 97% of those surveyed initiated the antimicrobial portion of post-exposure prophylaxis. By day 30, 52% reported discontinuing PEP, and by 60 days, only 33% reported completing PEP. The main reason for discontinuing PEP early was low perceived risk of exposure at 64%, followed by experienced adverse events at 35%. This slide shows modeling assumptions for PEP adherence done by the Department of Health and Human Services. The modeling assumptions were loosely based on the PEP adherence rates observed after the 2001 anthrax letter incident. The main source is the Shepard 2002 EID article I presented a few slides ago. You can see here that the model predicts a drop of about 25% every 2 weeks. In this model, adherence is around 50% when the last dose of vaccine is given at 4 weeks. Another potential obstacle to efficient or effective anthrax post-exposure prophylaxis is adherent to the 3-dose vaccine series. Predicting adherence to anthrax vaccine is challenging as there are few data on the effects of adverse events and vaccine adherence in emergency situations. Dr. Hendricks will present data from the anthrax vaccine research program study used to evaluate an alternative administration route for pre-exposure vaccination, which we used as a surrogate for adherence to vaccine during an event. This study showed that IM administration of the AVA elicits far fewer local reactions than subcutaneous administration. This raised a concern that higher rates of adverse events might lead to lower adherence to the vaccine component of PEP. However, a look at dropout rates in this study showed that they were generally low and did not differ by route of administration. So now I will summarize the work group's decisions on operational concerns. The work group felt that the different length needles would not be an impediment to administration of vaccine. The 1-inch needles in the stockpile that are generally used for administering vaccines intramuscularly could be used to administer vaccines subcutaneously without compromising the efficiency of the response. There are data to suggest that adherence to antimicrobial components of anthrax post-exposure prophylaxis wanes over time and could be as low as 50% by the 3rd dose of vaccine. This finding caused some concern within the work group because, as you will see in Mr. Chifford's presentation, the immune response at 4 weeks is generally lower for the intramuscular route of administration compared to the subcutaneous route. The higher rate of adverse events for the subcutaneous route of administration was also a concern. However, data from the study describing adverse events in groups receiving IM and subcutaneous administration failed to show any difference in dropout rates by the different routes of administration. The small study that followed the lab incident at CDC showed low adherence rates with vaccine. However, it did not compare the intramuscular versus subcutaneous route. So I would like to now see if the ACIP committee has any questions or concerns with this data.
Dr. Kemp?
I had a question about the antimicrobials, the 3 antimicrobials that you're using. Are they equivalent in terms of effectiveness?
Yes, the Cipro and doxycycline are considered to be provide the same effectiveness as post-exposure prophylaxis.
And how about a MOX? Because that's listed as well?
Yes.
Because, I mean, they're very different in terms of tolerance. So I
Yes,
wonder
ma'am.
if, sort of prioritizing a MOX is tolerated by almost everyone, whereas the other ones I'm aware of more problems with. I just wonder if that's a thought.
It is not FDA approved as post-exposure prophylaxis, but we're working on getting that indication. And not to get into the weeds or anything, but there is the issue of antimicrobial resistance. There are naturally occurring strains that are resistant to penicillin, so we want to make sure that the strain that is being used is susceptible to penicillin before we use that. So the current plan is not to ship amoxicillin right away. I'm not saying that might not change, but the current plan right now is to not ship it for the first 10 days.
Hey, thank you. Okay. We move on to Dr. Hendricks.
I'm going to ask a question as Willie sits down, but I mean, there are similar vaccines that we're responsible for, like smallpox, where the general indication is actually laboratory work as an emergency response. So I don't want to be left with the impression this is outside the scope of what we ask ACIP, but I do want to make sure that we have enough of the people who would be actually implementing such a recommendation as part of the working group. And in my mind, those are actually the state and local preparedness folks. And so we probably do need to give a little bit of thought to who's on the committee and make sure that Nature or CST or somebody from that community also weighs in on issues, for example, of the practicality of two different needle lengths. So not just scientifically, but, typically we think about implementation and you all are the right group because you implement vaccines. But I suspect that most of you have not actually implemented in a disaster like this. And so I just want to ask that we look at that a little bit more.
I have been part of a point of dispensing demonstration. I assume you have too. Yeah.
Dr. Kim.
Oh, sorry. Okay. My talk is called Anthrax Vaccine Absorbed Safety Studies Since 2008. This safety talk takes up where the 2010 guidelines left off. The VAERS information, both published and recent unpublished information, is presented first. Then I'll discuss studies that relied on a variety of data sources other than VAERS. Just to note, the post-licensure AVA data are based on pre-exposure prophylaxis or PrEP uses. The mode of administration for pre-exposure prophylaxis changed from subcutaneous to intramuscular in 2008. The Vaccine Adverse Event Reporting System, or VAERS, is a national passive reporting system for adverse events, AEs, that occur following administration of U.S. licensed vaccines. It receives about 40,000 reports annually and accepts reports from a wide variety of reporting entities, including healthcare providers, manufacturers, and the public. Signs and symptoms of adverse events are coded using the Medical Dictionary for Regulatory Activities, MEDRA, terms, and entered into a database. Since 1990, it has been jointly administered by the CDC and FDA. The main objectives of VAERS are signal detection and hypothesis generation. It can detect new, unusual, or rare adverse events, identify potential risk factors and recipients for particular types of adverse events, monitor trends, and identify lots associated with increased numbers or types of adverse events. It enables a rapid response to vaccine safety concerns or public health emergencies. Adverse events are temporally associated events which might be caused by a vaccine or might be coincidental and not related to a vaccination. VAERS data must be interpreted with caution and cannot generally be used to assess causality. In recent years, there were 30,000 VAERS reports per year. 7% were classified as serious. VAERS reports are classified as serious if they contain information that the AE resulted in death, hospitalization, prolongation of hospitalization, life-threatening illness, persistent or significant disability, or congenital anomalies. This list I've just read explains the basis for a number of the studies that I'll be discussing in a few minutes. The strength of VAERS include the national scope of the data. It accepts data from anyone. In 2011 through 2014, healthcare professionals submitted 38% of reports, vaccine manufacturers 30%, and patients and parents 14%. Other strengths include the quickness with which it can detect a safety signal, its sensitivity for detecting rare adverse events. The type of data collected includes information about the vaccine, characteristics of vaccine, and adverse events. Another strength is the transparency of the collection system. The public can access the data. However, it does have a number of limitations. These include reporting bias. As with all passive surveillance systems, the problem is underreporting. Inconsistent data quality and completeness. You have non-medical people reporting medical information. There is no comparison group. Generally, it cannot be used to assess if the vaccine caused an adverse events. Pregnancy is inconsistently reported. Please note that the time period in this slide has changed from approximately 17 years to 17 months. The correction is indicated in a blue font. The original publication had an error which was later corrected. This 2009 study by New described VAERS reports following AVA receipt for a 17-month period ending in January 2007. During this time frame, 4,700 reports were filed, of which 4,273, or 90%, were non-serious, 455, about 10%, were serious, and 25 were death reports. The authors also noted that during a 9-year period ending in 2007, approximately 6 million AVA doses were administered to military personnel. 1/3 or more of the complaints were for myalgia, arthralgia, pain, and headache. 1/5 to 1/4 of the complaints were for depression, asthenia, rash, anxiety, insomnia, and back pain. The authors concluded that review of VAERS reports for this time frame did not definitively link any unexpected serious adverse event to AVA vaccination, other than injection site and some allergic reactions, and that review of serious and death reports did not suggest a causal relationship to vaccination. A 2011 study by Wu reviewed reports of thrombocytopenia to VAERS for all vaccines to identify any that might warrant further study for possible causal associations. The review included all thrombocytopenia reports defined as a platelet count less than 150,000 that lacked a clear etiology over a 17.5-year time period ending in 2008. Using MEDRA codes for thrombocytopenia, they identified just over 1,500 reports following exclusions for meningitis, cancer, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. 1,440 reports remained. 14 of these followed receipt of AVA. They concluded that since acute and chronic thrombocytopenia commonly occur in the absence of recent immunizations, post-immunization thrombocytopenia may have been coincidental. The following data are unpublished CDC data. From January 1st, 2009 through June 30th, 2017, VAERS received 2,439 non-duplicate reports from U.S. sources following receipt of AVA either alone or concurrently with other vaccines. Of these, 329 were considered serious events. In other words, they resulted in death, hospitalization, or permanent disability. The 5 deaths among AVA recipients were investigated. 3 had autopsies, 2 did not. Causes of death included a spectrum of cardiovascular disorders, unintentional or intentional injuries, and chronic illnesses. Approximately 80% of all reported adverse events that occurred after administration of AVA were in persons under 40 years of age. 25% occurred in women, 75% in men. Most received AVA concurrently with other vaccines, that would be 54%. And 46% received just AVA. 91% of AVA reports were documented as being administered or funded by the military. Approximately 1,770 different MEDRA terms were reported in conjunction with AVA from 2009 through June 30th, 2017. The 10 most common adverse events that occurred following AVA receipt, each occurring in 9 to 15% of the population, were headache, injection site erythema, pain, fever, fatigue, arthralgia, erythema, pain at the injection site swelling, rash. In conclusion, there were no new safety concerns detected in recent VAERS monitoring. The remainder of the studies presented are based on data sources other than VAERS. The next 2 slides compile data from a variety of studies. Some were dose reduction or schedule modification studies about AVA, and some were immunogenicity or adverse event studies of other vaccines, which included AVA as a control arm. Although not all mention the number of doses administered, I've calculated the doses by multiplying the number of study subjects in each arm times the number of vaccinations they were to receive. The denominator doesn't take into account dropout rates, which were usually small. As you can see, only 1 serious adverse event was reported in this group of studies, and it was deemed to be unrelated to the vaccination. The remainder of the studies in this slide did solicit both adverse events and serious adverse events and reported none. The denominator which we've created, doses, also does not address the length of follow-up, which varied from study to study and likely accounts for the increased numbers of serious adverse events identified in the Wright study, which followed more than 1,000 recipients for years rather than months. In this study, the Anthrax Vaccine Research Program, there were 231 AEs in the 8,300 doses that were given. 6 of these, all non-fatal, were considered to be possibly related to the vaccine. A study published in 2012 by Stewart evaluated quality of life of more than 1,500 18 to 61-year-old civilian participants from 5 Anthrax Vaccine Research Program, or AVRP, study sites. The AVRP was a randomized, double-blinded, placebo-controlled trial of immunogenicity and reactogenicity. A standardized survey instrument, the SF-36, was used to assess their health-related quality of life at baseline and at months 12, 18, and 42. A large number of health-related covariates, seen here on the screen, were accounted for in the analysis. The mean physical and mental scores decreased over the 3.5 years that the group was followed. However, there was no evidence that the score difference from baseline varied among the 7 study groups, 2 of which were saline placebos. The authors concluded that the results do not favor an association between receipt of AVA and altered health-related quality of life over a 42-month period. In 2015, King et al. Published a reanalysis of existing data sets that compared 18 to 20-year-olds to adults aged 21 to 29 years of age who had participated in 4 previous U.S. government-funded AVA studies. He found that rates of elicited adverse events were not significantly different between younger and older age groups or either local or systemic events, and that there were robust and similar proportion of seroresponses to vaccination were observed in both age groups. The authors concluded that AVA was safe and immunogenic in 18 to 20-year-olds compared to 21 to 29-year-olds. The next 7 studies are done in military populations. This one, published by Phillips in 2009, evaluated whether there was a relationship between squalene and chronic symptoms in a cohort of Gulf War veterans. This appears to be just one of many hypotheses that were being investigated to assess possible associations with chronic multisystem disease. However, before I get into the study, let me give you a little bit of background information. Squalene is a naturally occurring substance produced by the liver to help metabolize cholesterol and combat physical injuries. Although squalene has never been added to AVA as an adjuvant, trace amounts have been found in 3 U.S. vaccines, including AVA. Okay, so back to the study. About 500 deployed Gulf War veterans and just under 1,000 non-deployed veterans were assessed by means of a questionnaire and laboratory tests. The following groups were demographically similar: participants and non-participants, squalene antibody positive and squalene antibody negative veterans, ill and well veterans. Squalene antibodies were similar in deployed and non-deployed veterans and were not associated with chronic multisystem disease illness. The authors concluded that there was no association between squalene antibody status and chronic multisystem illness. The next study, published by Sulsky in 2011, is a cohort study evaluating the potential for long-term or delayed health effects from anthrax vaccination. U.S. Army personnel active during a 7+ year period from December 15, 1997 through February 15, 2005 were eligible cohort members. After all exclusions, the cohort comprised just over 1 million soldiers. About 44% had received at least 1 dose of AVA. A variety of military databases were used to identify the cohort and any disabilities that they might have. The organ systems that were evaluated are listed on the slide. Just above 5% of the cohort was evaluated for disability. Unadjusted rates show those receiving at least 1 dose of AVA were nearly 3 times less likely to have been evaluated for disability than unvaccinated personnel. The authors used multiple logistic regression models to investigate whether the odds of dose of disease increased with more doses of AVA. Only among soldiers with 2 years of service who entered the Army in the year 2000 or later was a dose-related increase in odds of disability evaluation. In contrast, soldiers who enlisted before 2000 had a dose-related inverse trend in risk. As there were no changes in the formulation, dosing schedule, or mode of delivery of AVA during the study period, the authors concluded that the difference in direction of the dose-response association based on calendar year of enlistment suggested a statistical artifact, rather than a true biological difference in risk associated with vaccine doses. The authors concluded that there was no consistent pattern or statistically significant difference in risk of disability evaluation, disability determination, or reason for disability associated with anthrax vaccination. The next study, also published by Sulsky, is a case control study nested within the cohort of all active duty personnel known to have separated from the Army during an 8-year time period ending in 2005. Again, the data were pulled from a variety of military data sets. Cases had been determined to be at least 10% disabled, either by the Army prior to separation or by the Veterans Benefit Administration after separation. Controls had separated without disability and were not on VBA disability. The authors used logistic regression to adjust for a variety of demographic and work-related variables. After adjustment for covariates, veterans who had been vaccinated against anthrax had lower odds of later receiving VBA benefits than their unvaccinated counterparts. There was no association between prior vaccination against anthrax and odds of disability separation from the Army overall. The authors concluded that the risk of disability separation from the Army and receipt of disability compensation were not increased in association with prior exposure to AVA. This study provides evidence that vaccination against anthrax is not associated with long-term disability. The next study, published by Duderstadt in 2012, was a retrospective population-based cohort based on data from the Defense Medical Surveillance System. In this study, the authors assessed whether vaccination with AVA increased the risk of type 1 diabetes. The population included about 2.3 million active component U.S. military personnel, 17 through 35 years of age, who were followed for 7.6 million person years. Over a 7-year time period ending in 2008, they identified incident type 1 diabetes from ICD-9 codes. They found just over 1,000 new cases. Multivariable modeling that adjusted for a variety of demographic, work-related variables and receipt of one or more of the study vaccines was used to examine the risk of diabetes. The authors concluded that compared to their unvaccinated counterparts, AVA recipients were not at increased risk for type 1 diabetes. This next study, published by Bardenheyer in 2016, is a case control study that evaluated the relationship of rheumatoid arthritis and systemic lupus erythematosus, hereafter referred to as RA and SLE, with AVA vaccination. The military database that was used appears on the screen. The population included U.S. military personnel on active duty during an 8-year time frame ending in December 2005. RA and SLE cases for both inpatient and outpatient settings were identified based on ICD-9 codes. After matching for sex, age, and service branch, conditional logistic regression models that controlled for deployment status were used to estimate matched odds ratios for AVA exposure during various time intervals ranging from 3 months to 3 years before disease onset. Rheumatoid arthritis cases, there were 133 of these, were no more likely than controls to have received AVA in the previous 3 years. However, they were more likely to have received AVA in the previous 3 months. There were far fewer cases of SLE. There was no increased risk of SLE in AVA recipients compared to their unvaccinated counterparts. The authors concluded that AVA was associated with a recent onset rheumatoid arthritis and may have acted as a trigger in predisposed individuals. However, AVA receipt did not increase long-term risk for either rheumatoid arthritis or systemic lupus. The next 2 studies are both by Conlin. The first was a retrospective cohort that looked at pregnancy and infant health outcomes in women who were inadvertently given AVA while pregnant. Data regarding women who were exposed to AVA while pregnant were ascertained from the National Smallpox Vaccine and Pregnancy Registry and electronic healthcare data. There were 463 women in the primary analysis. 155 only received smallpox vaccine and were unexposed to AVA, and 308 received both vaccines. A study limitation was their inability to control for potential confounding. Compared to military women exposed to neither vaccine, both the unexposed and exposed groups had similar fetal outcomes with regard to ectopics, elective and spontaneous ABs, and stillbirths. They also had similar infant health outcomes with regard to preterm births, low birth weight, mean birth weight, male sex, and major birth defects. The authors concluded that the similar rates between AVA exposed and AVA unexposed groups provided further confidence in the safety of AVA when given inadvertently to a relatively young and healthy population during pregnancy. This next study was published last year by Conlin. It's a retrospective cohort study of infants born to military women from 2003 through 2010. The study population includes 126,000 live-born infants. Mothers were categorized by AVA vaccination exposure timing in relation to pregnancy. Infant medical records were assessed for birth defect diagnoses within the first year of life. Multivariable logistic regression was used to calculate odds ratios and confidence intervals. Variables in the multivariable analysis included birth year, sex, and plurality for the infants, and a variety of demographic and service-related variables for the mother. It did not adjust. Here we go. When women who received AVA in their first trimester were compared to women who received AVA any other time, Pre-pregnancy, post-pregnancy, or never, the risk of having a child with a birth defect was not increased, as demonstrated by the odds ratios that hover near 1 on this slide, and which all have confidence intervals that overlap 1. The authors concluded that there was no strong association between inadvertent AVA vaccination during pregnancy and birth defect risk. In 2014, Wright et al. Published the portion of the anthrax vaccine research program that evaluated alternative administration routes, reduced schedule priming series, and increased intervals between booster doses for AVA. Both immunogenicity and reactogenicity were assessed. This slide shows the dosing schedule for the 7 study groups in that paper. It was a double-blind study. Everyone was dosed with saline when they didn't receive AVA. The AVA doses are shaded a maize color, and the saline doses are shaded light blue. The top 2 rows are the 8 sub-Q and the 8 IM groups, which were dosed at months 0, 1/2, 1, 6, 12, and 18 months, and then boosted at 30 and 42 months. All the reduced schedules skip the half-month dose. At the bottom are the 2 placebo groups, sub-Q and IM. The immunogenicity data from Wright will be presented later today by Mr. Schiffer. One finding in Wright was the differences in injection site reactions between the IM and sub-Q routes of administration for AVA. Itching, edema, and bruising were less likely overall in participants who were vaccinated by the IM rather than the sub-Q route. Warmth, erythema, induration, and nodules were less common in both males and females who were vaccinated by the IM rather than the sub-Q route. For injection site reactions, only arm motion limitation was more common in recipients vaccinated by the IM rather than the sub-Q route. For systemic reactions, muscle aches were significantly more common in IM than sub-Q recipients, and there was a slight but non-significant decrease in fatigue seen in IM recipients compared to sub-Q recipients. In conclusion, there were no new safety concerns that have arisen since December 2008 based on updated VAERS review and a review of the published literature. Injection site reactions were significantly less common with IM than the sub-Q route of administration. Okay.
Thank you very much. That was an amazing review of the literature, and we appreciate it. Are there questions? Guess not. I guess we'll move on to the next presentation.
Hi, I'm going to review the immunogenicity data that supported the recent changes to the anthrax vaccine licensure. The current license indications, as mentioned by Dr. Bauer earlier, are for pre-exposure prophylaxis by the intramuscular route. The regimen was simplified in 2012. There was a reduction in the priming series to 3 IM doses at 0, 1, and 6 months, down from 5 IM doses going out to 18 months. This results in protection being achieved in 6 months and shortening the priming series by 12 months. There's also been a new indication approved for post-exposure prophylaxis, and I apologize for the typo, it's in 2015. That approval is for the subcutaneous route, and it is a 3-dose series at 0, 2, and 4 weeks with co-administration of antibiotics for 60 days. To review the progress of the disease, anthrax is a toxin-mediated disease. Anthrax toxin consists of 3 proteins: lethal factor, edema factor, and protective antigen. Lethal factor and protective antigen combine to form lethal toxin. Lethal toxin, when taken up by cells, can cause cell lysis and affects primarily immune response cells. Edema factor and protective antigen form edema toxin, and when that is taken up by cells, it produces cyclic AMP and produces edema. Protective antigen is a carrier protein. It has no toxic activity on its own, but is required for the activity of lethal factor and edema factor, and it is a primary immunogen in the vaccine. So AVA vaccine produces antibodies against protective antigen. Those antibodies can bind to either free PA or the complexes and block any of the steps of intoxication. This protects the host immune cells from intoxication, allowing a normal immune response to clear the bacterial infection. The immune response does include other components, including cellular responses, but antibody level at the time of challenge has been shown to be an accurate correlate of protection in animal models. The primary ways we measure the immune response are anti-PA IgG ELISA. This measures the total amount of IgG against PA in micrograms per mil. It does use a species-specific reference standard and conjugate. The reference standards were calibrated independently, so there is the potential for miscalibration between species. The toxin neutralization activity assay measures the ability of antibodies to neutralize lethal toxin. It is not specific to the antibody subtype, and it is also species independent. The TNA units are reported in varying studies in two different units. One is the effective dose 50. This is the reciprocal of the serum dilution that neutralizes 50% of the in vitro lethal toxin cytotoxicity. The scale is generally from around 50 up to around 10,000. The neutralization factor 50, or NF50, is the ED50 of the sample divided by the ED50 of a reference standard on the same run. This helps normalize out run-to-run variation, but it does make the NF50 specific to the reference standard used. All the data we'll be presenting were done with the same reference standard, which is AVR 801. It also changes the scale, NF50 scale, from approximately 0.1 up to about 10. The VRBPAC meeting in November 2010 reviewed pathways to licensure using the animal rule for AVA. Their final recommendations were that antibody levels are an appropriate marker to use for bridging between animal efficacy and human immunogenicity. They recommended bridging using the Koberger method as an appropriate model for predicting human survival from animal challenge data. And they also approved using a PrEP animal model design for doing the PEP licensure. Fay et al. Did a interspecies bridging meta-analysis where they analyzed all of the government-sponsored animal challenge trials that had been done since, I believe it was 1999. They covered 2 different non-human primate species plus rabbits to see what factors affected the bridging between animal species when you know the survival data in both species. They identified that genus and species were important, that bridging between different non-human primate species was more accurate than bridging between rabbits and non-human primates. The vaccine formulation mattered, vaccine schedule matters, the time of immune response and the time of the challenge matter. So the immune response changes over time. If you measure the response at a specific time as a predictor, you have to use the same time in your comparison group if you're bridging between the humans and the animals or between 2 different animals. They only used the TNA assay because it was considered to be species neutral. The studies that support the recent AVA changes are the CDC Anthrax Vaccine Research Program, which Dr. Henderson also talked about. It was a phase 4 human clinical trial. It compared the intramuscular and subcutaneous routes in the original PrEP schedule and evaluated reduced booster schedules in the IM route out to 42 months. There was also a matched non-human primate non-clinical trial where non-human primates were given the 3-dose IM priming schedule and then subjected to anthrax lethal challenge to measure duration of protection at the extended times of 12 months, 30 months, and 52 months. There's also data by the Emergent Biosolutions pivotal PEP trial. This was a phase 3 human clinical trial. It used the subcutaneous route only. The decision to use the subcutaneous route was based on data from the AVRP that I'll be presenting momentarily. It followed the PEP schedule of 0, 2, and 4 weeks and measured immunogenicity out to day 70, which is just past the end of the antibiotic prescription. It contained a matched rabbit and non-human primate non-clinical challenge trials. The animals were vaccinated at 0 and 28 days and then subjected to high-dose anthrax lethal challenges at day 70. First, we'll discuss the PrEP priming series change. So this was based on a subset of the AVRP immunogenicity data, looking at the human clinical trial data using the licensed route, intramuscular, and schedule at 0, 1, 6, 12, and 18 months. The magnitude of the anamnestic response to the month 6 dose was shown to be comparable to the response at months 12 and 18. This indicates that priming was complete after the month 6 dose. There we go. This is the anti-PA IgG data, so total anti-PA IgG. And as you can see, the 3 time points in the red square are the responses at months 7, 13, and 19 to the months 6, 12, and 18 doses. This is the same groups by the TNA ED50, and again, the results are comparable. And just for completeness, the data is also provided in table format where you have the confidence intervals and the numbers. There was no statistically significant difference between the concentrations measured by either assay at month 7 and month 19. So in 2012, FDA approved the priming schedule, simplifying the dose series from 18 months down to 6 months. The primary impact is on time to deployment or approval to work for emergency responders and laboratory workers. Prior to that, they were having to wait for a full 18 months before they were deployable. So there is a significant impact on response activities. Now we're going to talk about the PEP licensure. So the PEP studies were designed only using the subcutaneous route for the human clinical trial. This was based on the AVRP data where they compared subcutaneous to IM routes for the PrEP licensure. While IM had reduced frequencies and severity of injection site adverse events, as Dr. Hendricks discussed in the previous presentation, the work group and the FDA both felt that the rapid onset of immune response was prioritized over reducing AEs. The subcutaneous route has a statistically significantly higher immune response at week 4 as measured by the total anti-PA IgG. So you can see here at week 4, the IM in red is lower than the sub-Q in black, and the difference is significant. By week 8, and for the rest of the study, they were not significantly different. By the TNA assay, they were still different, but not statistically significant. The confidence intervals were overlapping, but IM still appears to be, sub-Q still appears to be slightly higher than IM. And again, I've also provided the data in tabular format so you can see the exact numbers and the confidence intervals. So the PrEP animal model was used for PEP licensure. PEP licensure is intended for use with concomitant antibiotics. However, when they attempted to develop an animal model using concomitant antibiotics, they were unable to generate any animal death. Even very low vaccine doses with antibiotics gave 100% survival. And if you don't have some animals die, you cannot generate a correlative protection and establish a protective requirement level. They did do studies that showed that the antibiotics do not interfere with vaccine immunogenicity and that vaccination can provide improvement over antibiotics alone. So the PrEP model that was used is that rabbits or non-human primates were vaccinated with graded vaccine doses at 0 and 4 weeks to generate a range of immune responses from highly protective to poorly protective. They were then subjected to a high-dose aerosolized Bacillus anthracis spore challenge at day 70. The model was designed to be very conservative. The high-dose challenge of 200 LD50s should be far larger than residual spores left in the lungs at 70 days post-exposure. The TNA NF50 was used as the reportable value for the antibody response. Logistic regression was used on the animal models to generate a correlation between the antibody response and survival in the animals. And in the antibody level that was required to provide 70% protective was used as a protective threshold and applied to the human immunology results. This is the rabbit model correlate. So in this graph, you can see the rabbits that survived are shown as the open circles at the top of the graph. The rabbits that succumbed to the challenge are the circles at the bottom of the graph. The logistic regression shows the prediction of survival based on the NF50. And they established an NF50 threshold of 0.56 that provided 70% protection in this trial. As a side note, in a later presentation, we'll be presenting more recent data. They've added additional animals that have shifted that threshold down, but this is the data that was used for the licensure. In non-human primates, there was a slightly different response. Again, the circles at the top represent animals that survived, at the bottom, those that died. And now there is the regression prediction curve for the animals. The 0.56 threshold would now predict almost 90% survival in the non-human primates, and a 0.29 NF50 response would give 70% protection in the non-human primates. And again, Fay et al. Indicated that the closer related the animal model is to the humans, most likely that has got better predictive accuracy, but both thresholds were applied for this licensure. The human arm of the clinical trial had participants vaccinated subcutaneously at 0, 2, and 4 weeks. The NF50 was measured out to day 63, and the percentage of human subjects who achieved greater than 70% protection at day 63 was used to evaluate the vaccine efficacy. They picked day 63 because that would be 3 days again after the ceasing of taking antibiotics if they're fully compliant. And just as a note, this is a simplified bridging model, not the full Koberger method that was recommended by the VRBPAC. And the results, this is taken from the BioThrax product insert. Based on the rabbit model threshold, 71% of the humans would have been greater than 70% protected, and 93% of the humans would be greater than 70% protected based on the non-human primate threshold. So in summary, there have been 2 changes to the BioThrax licensure since 2010. The PrEP priming series has been simplified from 5 doses over 18 months to 3 doses over 6 months. based on the magnitude of the human anamnestic responses to the month 6 dose compared to the month 18 dose. And the PrEP licensure has been granted with a 0, 2, and 4-week subcutaneous schedule with concomitant antibiotics for 60 days. The subcutaneous route was chosen based on superior immune response at week 4, and the licensure was based on the percentage of humans' responses exceeding the 70% protective levels established in both rabbit and non-human primate animal challenge models.
Thank you. Are there questions? Anybody? Thank you for that very nice presentation. And then I think we have a summary from.
Yes, thank you. I know we're over time, so I will try to go over quickly. So the anthrax work group felt that there were no new concerns based on the VAERS review or the data published since AVA was last reviewed in 2008. This data continues to support the safety of AVA for use as pre-exposure and post-exposure prophylaxis given the high mortality associated with anthrax. The work group felt that more data are needed to evaluate the safety of AVA in pediatric populations. However, although data are not available in children regarding the types and frequency of adverse events after immunization, the benefits of AVA in children exposed to aerosolized Bacillus anthracis spores are currently believed to outweigh these potential risks. Dr. Shiver just presented data on the pre-exposure change that occurred in 2012 from a 5-dose IM over 18 months to 3-dose IM over 6 months. We plan to include that in the revised recommendations. So now, after reviewing the data on intramuscular administration of AVA, the work group was not in favor of recommending it as an alternative route of administration during an anthrax event. The work group felt that the needles contained in the CDC stockpile could all be used to administer AVA by the subcutaneous route and would not be an impediment to administration of vaccine. The work group also felt that the intramuscular administration would not be more efficient than subcutaneous administration. The high rate of adverse events for subcutaneous route of administration was a concern. However, this is a theoretical concern as there is no data to show that this would translate into decreased adherence in an anthrax event. The issue that carried the most weight in the work group's discussion was that adherence to antimicrobial component of PEP wanes over time and could be as low as 50% 4 weeks after initiating PEP. This is particularly concerning because as Dr. Shiver showed, the immune response to AVA at 4 weeks is significantly lower for the intramuscular route of administration compared to the subcutaneous route. So the work group concluded that the data do not favor a change from the current licensed route of administration of AVA for post-exposure prophylaxis. This is supported by the data that the optimal immune response at 4 weeks is obtained by administration of AVA by the subcutaneous route. However, if AVA is inadvertently given by the intramuscular route, the work group advised that there is no need to re-administer the dose by the subcutaneous route. The corrective action is to complete the rest of the series subcutaneously. So, summarize that real quick. If anybody has any questions.
That was excellent. Thank you. Questions? Dr. Massonia.
Thank you, Willie. I wanted to make sure you all had some time to think about this, since this is a disease that you don't think about that much. But this is a complicated equation to balance all these issues. And I'm not sure the right answer, but I want to make sure that all the pieces are laid out in a fair way. And so I just want to go back to maybe 3 things and ask you all to think about them. I am interested in hearing from folks who actually would have to operationalize this if they think the issues around the different needle sizes and potentially 2 different vaccines that are being administered differently would realistically be easy at the field, or if that should be given additional consideration. The issue around adherence, I have to say, for full disclosure, I'm the senior author on the paper that he's referring to, and I actually say that the data perhaps wasn't presented as I would have presented it. So for those of you who are around in 2001, you may remember that substantial numbers of those people were recommended antibiotics well after their exposure, like months. And so in New York City and New Jersey, it's not just risk perception, it's that we told people you were exposed to anthrax 6 weeks ago, we want you to take antibiotics now. So I think a better metric of adherence was in the people within those subgroups who actually really saw themselves to be at risk. And that isn't fully displayed, and perhaps in the paper not fully displayed, but it's subcategories in each of those states. And the data in those people in those subcategories who really felt the risk of exposure are actually much different and much higher. So I'm not sure that that 25% number is the right number to use. In those higher groups, it was somewhere more like 60%. And then the final thing is this issue around how to deal with the immunogenicity data is very complicated, and purely based on immunogenicity data, you see differences. But I also understand, and I haven't been in this field for a couple years, but that the interpretation of these cross-species animal model is a point of much contention among the researchers who work in this field. And that, I guess I'm not sure I can fully explain it, and I'm not sure if Conrad wants to make some comments about it. Hi, Conrad. But it is a complicated area, and I think the folks at FDA also struggle with how to interpret that data. And in the 10 or 15 years since these studies started and people have turned over, some of the perceptions have also changed. And I have to say that I'm struggling a little bit to, I don't think the view is as simplistic as antibody levels are different, and therefore there's a straight line conclusion that predicts protection would be different. So I just wanted to provide that context, not to make it more confusing, but to tell you that I do feel like you guys have some things you need to struggle with here.
Mr. Hunter.
So did the work group look at any of the data related to vaccine administration errors in clinical practice regarding needle length and various other vaccine administration errors?
No.
I think you would be, might have come to different conclusions if you had done that, given the frequency that occurs. I don't know that data well, but I know that it's quite concerning.
Okay, thank you.
But I do think, just to remind people, that we're considering the scenario where these vaccines would likely be administered not in a private practice type of setting, but more by public health.
Being the person that reviews the vaccine administration errors of 50 or more public health nurses, you need to have reports of vaccine administration errors to make sure that they are doing their job correctly, because if they aren't having errors, you know that they're not reporting it correctly. It's just like flying an airplane. You have to report the errors that you've had on things, otherwise you aren't doing your job correctly. Yeah, I think I wouldn't. I would think that in especially in emergency response situations, and in the chaos I experienced in the demonstration, I would have even more concerns personally.
Yeah, and just to add to that, as you could imagine, if you're wanting to have a mass vaccination campaign involving hundreds of thousands or millions of people, you're going to be recruiting people who are not familiar with, or maybe as familiar, or you'll be doing just-in-time training. So that was another reason why we wanted the simplest way to administer the vaccine. Yes, ma'am.
I just wanted to bring up your comment about pediatric use, and I'm thinking about two things in particular. You said there were a need for more studies of the vaccine in children, so I wondered whether that was something that was going to be planned going forward or not. And then the second question was around treatment and clinical disease, and I can come back to that one in a second.
Okay, well, there is a plan to look at this vaccine in children, and it's I'm not sure the best way to describe it, but it's a de-escalating where they're going to start with like 17 to 18-year-olds and do it in that and show that it looks good in that. Then they'll go to 15 to 16, or 16 to 17-year-olds and see. So it's going to take them a long time to go all the way through the different age groups, but that's the current plan for how they're going to look at the vaccine in the pediatric population.
And this would be sub-Q, correct?
But that would be in the event of an event. I think Bonnie is asking if there are any plans to do pre-event clinical trials in pediatric populations.
I thought that there was.
I think that the funding was, there is a study protocol, but I don't think there is funding that's been allocated for that.
Well, but, just looking at the issue around pediatric disease, first of all, our guidelines are pretty limited now because we're using adult guidelines as we do for many other vaccines and antimicrobials. But if you look at reviews of disease in children, they are quite atypical. So even the ability to identify children compared to adults is going to be a little different. And there's evidence that the mortality rates in kids are higher than in adults as well. So the AAP would encourage, if possible, more studies around vaccine use and also PAP as well.
Dr. Kimberlin?
I'd just point out that, 23% of the U.S. population is children. And so if they could vote, that might stimulate some of the direction of funds.
Thank you. Dr. Gravenstein?
Hi, John Grabenstein from Merck Vaccines, more relevantly, alumnus of the United States Army. To Dr. Maldonado's point, there is it's not just that there's no safety data in children, there's no immunogenicity in children because there's no dosing data in children. And so politely we could say there's not funding, but I'm not sure that there is will. So what is the presumptive dose for a child? You would start with, well, we give the same dose of tetanus toxoid to an adult as we give to a 2-month-old, so we'd start there. But until somebody studies it, that's the only basis you'd have for dosing.
Thank you. Dr. Bresnitz.
Ed Bresnitz, Merck. This is a personal comment, not because I'm a Merck. I was a New Jersey state epidemiologist during the anthrax attack and was exposed in the postal facility. So I had the unenviable opportunity to take Cipro for 60 days. It wasn't very pleasant, and that was a minor adverse event. But just a comment on the anthrax program, and I don't know whether it came up today because there's a lot of detail, but at the time it was, the whole program was after the fact, if you will, when it sort of was a late, and it was under an IND, and it was 3 doses, not 6 doses. And frankly, I didn't support the program in New Jersey. I mean, I wasn't against it. I just said it's up to you to take it. I didn't support the CDC on that. There were very few people who took it. Also, it was 75 days, I think, after exposure. The point I want to make is that the key here, of course, policy was being developed on the fly at that time. We were really flying by the seat of our pants. CDC was, states were. The key here is communication. And I think there's a lot of work that's been done over the last 15 years, I guess. It's hard to believe it's been that long. But I think the communication in the time of an exposure is really the key here to getting whoever's exposed to either take antibiotics or get vaccinated or do both. That's really what, tell them what to anticipate in terms of potential adverse effects, tell them what their risks are, tell them why they're taking it, and so on. And then you'll get better adherence rates as well, and really do tailor their risk to what their real risk is. You know, in New Jersey and in Brentwood, the risks were high. In Florida, potentially, and in New York City, maybe the risks weren't that great. Thank you.
Thank you. Dr. Quinn?
Conrad Quinn, CDC. To follow up on Dr. Massania's point about IM versus sub-Q, if we look at the point estimates of the responses in the humans, clearly the sub-Q gives a higher response in the early weeks, but the IM catches up by week 8. Also, we'll be giving antibiotics during emergency response. The animal data indicate that both routes of administration give very high-level predicted probabilities of survival. So as we move forward, I'd just like to keep the door open to use either or, depending on the situation that we're faced with in an emergency response. It will be very challenging.
Thank you. And with that, I think we will move on to our last 3 quick updates. First, we're going to hear from Dr. Carr about the evidence-based recommendations group.
Hi, so please excuse my slightly scratchy voice. So I'm going to provide a brief update on the progress of the evidence-based recommendations work group. So the purpose of the evidence-based, here, let me flip slides. So the purpose of the evidence-based recommendations work group is to provide a forum for discussion of the best practices for evidence-based recommendation process for ACIP. This includes both the development and use of grade evidence tables and the process of moving from the evaluation of the evidence base to formulation of the recommendation. So in support of this purpose, the aims of the work group, as defined in the terms of reference, are to propose additional guidance for the ACIP evidence-based recommendation process, specifically for 3 areas: improvement and harmonization of the development and use of grade evidence tables by the ACIP work groups, developing criteria to guide the determination of when grade evidence profiles should be prepared in support of a recommendation, and finally, further defining the process of going from the certainty of the evidence base as presented by the grade tables to the recommendation, in particular, ensuring that the additional factors that contribute to decision-making are considered and communicated. So regarding the first aim, to harmonize development and use of grade tables, several CDC work group leads presented their experience using grade methodology for past recommendations to the work group. The 4 items listed here are among some of the areas that were identified for which additional guidance would be useful. First, applying grade methodology to the evaluation of immunogenicity data, including further clarifying whether and/or when evidence should be rated down for indirectness when used as a surrogate outcome for efficacy. Secondly, the acceptability of rating up a body of evidence after having previously rated down. Third, the assessment of observational data using grade, in particular, ensuring that the confidence generated by strong observational data is reflected in the ultimate evidence rating. And finally, the evaluation of burden of disease. So the next step for moving forward this goal of harmonizing the development of grade tables are to develop draft frequently asked questions documents that will provide more explicit guidance on how to consistently approach topics that often generate questions during the use of grade by ACIP work groups. So the second aim of the work group centers around providing reference materials to clarify when grade evidence profiles should be prepared when evaluating the evidence for a recommendation. A draft algorithm has been developed that provides questions that should be considered when deciding whether it would be advantageous to prepare evidence tables. This algorithm will be piloted, and any revisions will be incorporated in the reference materials. So the third aim of the work group is to provide additional structure and clarity for the process during which factors, in addition to the evidence base, are considered when formulating recommendations. The GRADE Working Group, a collaboration of methodologists, clinicians, and others working to develop, refine, and provide guidance regarding the GRADE evidence-based recommendation approach, have outlined a process to support movement from evidence to decisions. This has been termed the evidence to decision or evidence to recommendation framework. The framework is presented as a table that includes key background information, criteria that should be considered, and conclusions. So one advisory group that has adopted the evidence to recommendation framework is the World Health Organization Strategic Advisory Group of Experts on Immunization, or SAGE. And members of the SAGE Secretariat presented the framework currently in use by SAGE to the work group, in addition to discussion of the successes and challenges that have been so far encountered in their use of the framework. A recent example of a completed SAGE evidence recommendation table can be found on the WHO website at the link indicated here. So when queried about potential development of a similar evidence recommendation framework for ACIP, feedback from members of the evidence-based work group and CDC work group leads was positive. A draft ACIP-specific evidence recommendation framework has been developed based upon the SAGE evidence recommendation table and the GRADE evidence decision framework, with feedback from both the evidence-based recommendations work group and CDC work group leads. Each element of the framework has been customized to the needs of ACIP to provide additional structure and clarity in the communication of the spectrum of elements considered during recommendation development. And the draft framework is currently being piloted. So as mentioned previously, evidence recommendation frameworks are presented as a table that include key background information, criteria that should be considered, and conclusions. So the criteria that should be considered fall into several broad topic areas. Each of these areas contains individual questions that solicit judgments concerning each element and presentation of the available evidence. So the topic areas that are included in the draft ACIP evidence recommendation framework are shown here as follows. So the statement of the problem or the issue that the recommendation is intended to address, and this area covers presentation of information regarding why the issue is considered a public health priority. It will also include information regarding burden of disease and other considerations that contributed to the need for a recommendation to be developed. So the benefits and harms area includes both presentation of the available evidence for benefits and harms, as well as the certainty in this evidence. So the preparation of GRADE evidence profiles will typically be part of this section, or in circumstances where evidence tables were not prepared, a description of the rationale for the decision not to prepare tables. So the aforementioned when to prepare GRADE evidence profiles that was mentioned under AIM number 2 would be used as a tool to assist with this determination. And finally, the evaluation and determination of the balance of benefits and harms is also a key component of this criterion. So the values and preferences of the target population is another element of the draft framework, where consideration is given to the perception of the benefits and harms and how these are valued by potential recipients as well as providers. Consideration is also given to the acceptability of the recommendation to key stakeholders. And the resource use component of the framework encompasses the information provided by health economic analyses. And finally, the feasibility category includes implementation considerations. So a tool is also under development to assist work groups with completion of this section. So the rationale, evidence, and judgments that are made in the framework culminate in the communication of the type of recommendation. In the draft ACIP evidence recommendation framework, there are currently 4 types of recommendations that are possible. We recommend against the intervention, or the vaccine. We recommend that the intervention not be routinely recommended for all persons, but be available for individual clinical decision-making. We recommend the intervention, or we do not recommend the intervention at this time. So if the framework is formally adopted, implementation of the framework will result in the use of these 4 types of recommendations and will replace the labeling of recommendations as Category A or Category B. So the evidence recommendation framework is currently being piloted, and feedback from the pilots are being incorporated. In addition, the framework elements are being further defined and guidance developed on completion of the framework. We intend to present the draft framework to ACIP at the February meeting. So this slide summarizes the proposed timeline for development of additional guidance materials. In short, as mentioned, we hope to be able to present a draft framework at the February ACIP meeting. Guidance documents addressing the harmonization of GRADE table development and usage will also continue to be developed. And refinement of the materials will continue throughout the process, with the goal being presentation of the final materials at the June 2018 meeting. And I'd like to thank you for your attention, for still being here this late, and to recognize the many work group members that devoted a lot of time and effort to achieve this progress. Thanks.
Thank you, Dr. Carr. That was great. And I think we got some experience yesterday that was really very helpful in using the tables. Are there any comments? Yes, Dr. Kemp.
Just a quick question about the last category, not considered at this time. Is that supposed to indicate it an open-ended, we might be considering it? Is that why that is there?
Yes, so the work group members felt that it was important to include that instead of just having the option to recommend against an intervention, that there may be times when there isn't sufficient evidence, perhaps, or other factors that would lead them to say, we can't make a recommendation right now. We're not able to do that.
Dr. Moore?
Thank you. This is a very helpful framework. We got some experience practicing with it with the mumps group and with shingles, and I think it's going to be very helpful. A question: how does the evidence to recommendation process work when you have perhaps a general population for whom it may be less important? It could be a category B kind of equivalent, or maybe clinical decision making, but then for certain subsets of the population, it is routinely recommended. We have recommendations like that right now. How does that get handled? Do they have to be separate frameworks for each group, or how do they get blended together?
So that's some of the guidance that we're working on developing. And I think at this point, I would just say there are different ways that it could be approached. And it may depend in part on, again, on whether you can group similar populations together to have a draft framework for several different populations, or whether they could be included in the same framework. So it's really about being able to present the information in a clear and transparent way.
Dr. Salanti?
Yeah, two very quick points. I loved the process yesterday. I thought it was very helpful. You didn't mention it, but I also thought that the table that showed the pros and the cons of, was very helpful process to help people who are not on a work group think through it. And one other point, in terms of the preferences and values, it might be helpful to provide some guidance about the level of intensity, what kinds of data, the level of intensity, what do we really mean by preferences and values, what do we really mean, target population, are these providers, patients, some more guidance about that to try to harmonize that a little bit.
Thanks, I appreciate it. We are currently developing a guidance document that goes along that I think will be helpful, and we'll certainly make sure to include that information in there.
Certainly also for the target populations. I think that's... Mm-hmm. Dr. Gravenstein?
Hi, John Gravenstein from Merck. Curious on slide 8, how to interpret your comment about the resource use and cost effectiveness analyses. I'm wondering if you are moving towards, for the assumptions that go into the health economic analyses, if you're thinking of assessing the strength of evidence that underlie the various assumptions. I think that would have helped the committee considerably yesterday.
Okay, so so the resource use section, that's sort of the generic grade evidence to decision framework. And so the way that we are interpreting that then is by those health economic analyses. As far as presenting the certainty and the evidence around the underlying assumptions, I don't know, Amanda, I think you're...
So the way, and Wendy didn't show the way that it will actually look, but there's a place where, and this will all be, we will share drafts of this, but there's a place where there's comments on the evidence. So there's a summary of the evidence that goes into it, and then there's a comment section. And some of the questions that could be answered about the comments, under the comment section, for example, is how much data supported some of the assumptions, for example, in the analysis.
Thank you.
At the microphone.
Hi, this is Dana Minnie-Delman from CDC. Hi, Wendy.
Hi.
I was just curious on the evidence framework. Does it include information about when to conduct a systematic review, and specifically, if you are conducting your systematic review, guidelines for when a meta-analysis is necessary? Is that part of the framework?
So that's not actually part of the framework at this point. There's clearly some background information, again, that would go in that. And I think that there is some of that that's, and part of it may also have to do with what you're terming a systematic review. I mean, I think that there is always going to be an evaluation of the evidence that's available, and whether, you're going to go through the Cochrane methods for systematic review might be another story. And I don't know if that's what you're asking in particular, or whether, but there always should be an evaluation of the available evidence, whether it would meet Cochrane standards for systematic reviews, maybe another story.
Thanks, Wendy.
More critical questions. We will come back to this at our next meeting, but Dr. Schaffner.
Yes, thank you. And apologies for bringing this up yet again in this context, but an important public health aspect of vaccine and vaccine decision-making, namely the indirect effects of some vaccines, is not explicitly addressed. Think of pneumo, hepatitis A, HPV, and that's always bemused me that we don't have a specific assessment of that as part of the grade process, since it's obviously part of our important decision-making.
And thanks for that comment. That is something that has come up over and over again. It fits under part of the benefits and harms section. And so some of the specific questions that we'll share later with you, that's included under there. And there's definitely a plan to include that in the draft guidance because it is something that has, you're right, come up over and over again.
Hey, Dr. Langley. Update on respiratory syncytial virus.
Thank you.
Very much. I'm sorry I'm moving along so quickly, but I know we are rapidly approaching our end time, and I'm trying to get us out on time so no one misses their flights.
So good afternoon. I'm Gail Langley from the Division of Viral Diseases here at CDC, and I'm here to announce new terms of reference for the RSV ACIP workgroup. The RSV ACIP workgroup was formed in 2016 to evaluate the potential use of RSV vaccines in older adults. At the time the group formed, there was a vaccine product targeting the adult population in phase 3 trials. The vaccine candidate is now back in phase 2 development. There currently are vaccine and immunoprophylaxis products targeting infants in later stages of development. There is a maternal vaccine designed to passively immunize infants with antibodies in phase 3, and a monoclonal antibody product that would directly be given to infants in phase 2b trials. The ACIP charter states that the guidance will address use of vaccines and may include recommendations for administration of immune globulin preparations, shown to be effective in controlling disease for which a vaccine is available. Since the maternal vaccine and antibody products currently under development could result in overlapping recommendations, ACIP will develop recommendations for vaccines and antibody products that are licensed in the future. There will be 2 RSV ACIP workgroups, one to consider products targeting children directly or through maternal vaccination, the RSV pediatric workgroup, and one to consider products targeting adults, the RSV adult workgroup. There may be overlap in membership between the groups, and each will convene according to when products come closer to licensure. We anticipate the pediatric workgroup to start meeting the winter or spring of 2018. The RSV pediatric workgroup will review the epidemiology and burden of RSV disease in children and pregnant women, review the efficacy, immunogenicity, safety, cost-effectiveness of RSV vaccines and immune globulin products in pregnant women and children, provide evidence-based recommendations regarding use of RSV vaccines and newly developed immune globulin products in pregnant women and children, and identify areas in need of further research for informing potential future vaccine and immune globulin recommendations. The timing for reconvening the adult workgroup will be as needed. A copy of the new terms of reference are available upon request. Thank you.
Thank you. Any questions for Dr. Langley? No? Okay. Dr. Santoli.
Hi there. I have a very brief update. I know you've had a long meeting, so I want to give an update for vaccine supply. Part of this actually occurred in the Hep A section yesterday, so it's even a little bit shorter. We're just going to talk about hepatitis B vaccine supply. So, and this is actually similar information, although there are some updates to it, to a situation that was shared in our June meeting. So Merck is not currently distributing its adult hepatitis B vaccine, and it won't be distributing that vaccine through the end of 2018. The dialysis formulation, however, is not affected. And GSK has sufficient supplies of adult hepatitis B vaccine to address the anticipated gaps in Merck's adult hepatitis B vaccine supply during this period. However, preference for a specific presentation, such as a vial or a syringe, may not be uniformly met during this period. And then turning to pediatric hepatitis B vaccine, Merck is not currently distributing its pediatric hepatitis B vaccine through the end of this calendar year, 2017. However, GSK has sufficient supplies of pediatric hepatitis B vaccine to address the anticipated gap in Merck's pediatric hepatitis vaccine supply during this period, and the same caveat about presentation applies. Then just a reminder that we keep this link updated for all members of the public who would be interested in knowing the latest and greatest on vaccine supply updates. That's all I have.
Thank you, Dr. Santoli. Now, we just have a couple of comments, public comment. Don't think anyone's signed up, and I don't see anyone at the microphone, but...
We do have a couple of letters, if I can first mention. So in the ACIP members folders, we have a letter from NAPNAP around how we talk about healthcare providers and using more general language, which you all should have seen. Additionally, we had one public comment where there is a written statement that is not in your folders, but we will scan this and supply it to you after the meeting, and we'll include it. I will check and see if this individual wants it included in the record.
And with that, we are adjourned.